Okay, we're going to go ahead and start the residency presentations. Thank you very much for your patience, and I really would like to let you know it's not easy to come up and speak, and for a lot of the residents this is their first time to do this, so let's give them our attention, and it's taken a lot of effort for all of them to prepare these lectures. So the first lecturer will be Britney Staples. She is from the St. Louis residency program. She's a PGY2 resident, and she's going to come up and talk about ischemic and Charcot limb case. So, if you want a pointer, that's a pointer.
Okay.
There's the answer slide. Advance, go back.
Okay. Hello, thanks everybody for having us today. My name is Brittany. I'm from the SSM Health DePaul Hospital St. Louis program. And I'm going to go over a couple of cases while also keeping in theme with ischemic limb disease. So I figured since it's a group of residents and primarily podiatric physicians that I'd go into detail slightly about the biochemical etiology of critical limb ischemia. So critical limb ischemia patients, as we know, are at risk for significant loss and potentially fatal complications, progression of gangrene. Critical limb ischemia is defined as manifestation of peripheral arterial disease characterized by chronic inadequate tissue perfusion at rest associated with decreased quality of life and substantial morbidity and mortality. Lower extremity amputations due to peripheral arterial disease and limb ischemia gives rise to a 5-year survival rate of less than 30%, and as we know, patients who have received transtibial amputation are at a significant risk to receive a contralateral amputation within the next 5 years, and then following that, a 5-year mortality rate. So biochemically, as it was touched on earlier, nitrous oxide is the main transport system with regards to getting oxygen through the bloodstream. So it is synthesized through endothelial nitrous oxide synthase, also known as eNOS. And under physiologic conditions, eNOS is particularly activated by shear stress. Insulin alone is actually fully able to activate eNOS for the production of NO, resulting in vasodilation, angiogenesis, and the prevention of leukocyte adhesion, etc. Other activators include bradykinin, adenosine, vascular endothelial growth factor, also known as VEGF. So endothelial cells responsible for the maintenance of vascular tone. They're actively involved in the transport and distribution of nutrients and hormones, and the disposal of waste products. They are tightly regulated through the production of nitrous oxide and endothelin-1. Endothelin-1 is released by endothelial cells as a counterpart to NO, and it's activated through a conversion enzyme called endothelial conversion enzyme, ECE, activated by big endothelin precursor. I won't get too into the pathways for which this occurs, but this is provided on my PowerPoint, which you can find on the mobile app. Just another pathophysiologic slide. So vascular endothelial dysfunction is what leads to our critically ischemic patients, and the definition is where endothelium loses its physiologic properties. This results in a prothrombotic, pro-inflammatory state, and it can be the first step to the progression of atherosclerosis, cardiovascular disease, retinopathy, etc., all of these symptomologies that we see in our diabetic patients. The three main factors, which I'm not going to get into in detail, include hyperglycemia, insulin resistance, and hyperinsulinemia. And together, these can lead to diabetic microangiopathy, structural changes in endothelial barrier matrix, microalbuminemia, reduced vasodilator response, altered hemostasis, and increased inflammatory activation. So again, NO, vasodilation, angiogenesis, wound healing. So my first case is with a 45-year-old African-American uncontrolled diabetic female. So she presented to the emergency department complaining of persistent wound for approximately 2 years, which was non-healing in nature. Upon examination, her skin appeared slightly xerotic. Nothing was modeled, however, and her wound probed to approximately 2 centimeters, but didn't probe to bone. It was slightly malodorous and draining. So they were admitted for sepsis secondary to UTI and infected diabetic ulceration with a positive UA for trichomonas. White blood cell was 16.7, and she was immediately placed on vanxosin. Her pulses, however, were non-palpable. 3 days later, cardiology saw the patient, and the ABI obtained for the left foot was 1.16. At this time, podiatry had actually signed off given the stable nature of the wound, despite the fact that the cultures had grown strep group A and B and Klebsiella, simply because the vancomycin combination would cover those organisms. On the 7th, the AIF was performed, and interventional cardiology had discovered an occluded PT and determined that they would need to attempt a retrograde approach as they were not able to declot the vessel. Podiatry was then reconsulted the following day for digital discoloration and blistering along the dorsal aspect of the foot and ankle. So initially we had thought this to be sort of a reperfusion response, and we had come to the conclusion that it was likely that she had shower emboli from the declot from the AIF. So you can see her lesser digits are changing in discoloration, and she's developing gangrenous changes, and then the blistering was pretty significant, and you were not able to palpate any pulses below the blistering. So infectious disease had decided that this was not of an infectious etiology and discontinued Zosyn. Interventional cardiology had performed the retrograde AIF and opened the PT to 75% the following day. Following the increased discoloration of the lesser digits, we spoke with cardiology, and they took her back to the cath lab and stated that the PT was still patent. However, the patient remained gangrenous and continued to worsen. As you can see, the demarcation is extending to the plantar aspect of the midfoot, and her skin is completely sloughed on the dorsal aspect of the midfoot. These wounds were treated with silver sulfadiazide. So infectious disease and interventional cardiology kind of had a back and forth about what was to blame, and infectious disease claimed it was not infectious in nature, and cardiology claimed that it was, and that was the reason for the gangrenous changes. So an MRI was ordered. No osteomyelitis, no abscess, nothing was shown on MRI, but despite that, due to the persistent nature of interventional cardiology, we took her to the OR for a debridement, which revealed no abscess, no purulence, no persistent malodor. So ultimately, we were left with this gangrenous change, and you can see where her original ulcer was right here. So she came in with this, and then she left with this, and it was really unfortunate. We had offered her a TMA, to which she refused, and she was ultimately lost to follow-up after being placed in a skilled nursing facility. Case 2 is the Charcot case. It's a 46-year-old Caucasian female who presented with increased swelling and edematous change to her lower extremity. She has past medical history significant for diabetes, kidney disease, and she was on dialysis in line for a kidney transplant. So originally presented with non-traumatic grossly swollen midfoot, radiographs indicated spontaneous dislocation of the medial and central columns of the Liz Frank joint, as well as medial column and navicular disarticulation. We classified it as Eichenholz stage 1, and of course the initial treatment would be offloading for edema reduction techniques and non-weight bearing. So shortly after, once edema had been controlled, an ORIF was performed with arthrodesis of tarsometatarsal joints 1, 2, and 3 with navicular and medial cuneiform and intermediate cuneiform. A medial 1/3 tubular locking plate with spanning screws was placed across the medial aspect of the midfoot, as you can see. Shortly after, the patient had been completely non-compliant and been 100% weight-bearing on the foot. The films, when she returned a few months later, indicated significant abduction of the forefoot and loss of correction with collapse of the midfoot in the sagittal plane, as well as breaking of the internal hardware. So this was the foot upon return. And further revision needed to be performed because in order to receive her kidney transplant, she needed to pass a walking treadmill test. So the revision operation consisted of a biplane transpedal wedge osteotomy of the midfoot, a gastroc recession, and posterior calcaneal osteotomy. A bing-bing screw was also inserted across the medial column from the Liz Frank to the talonavicular joint in order to maintain stability in the non-compliant patient. A semitubular locking plate with locking screws was applied medially with the insertion of a 4-5 spanning screw. Her midfoot was then corrected and a transverse frontal and sagittal plane. So this patient actually did fairly well with no dehiscence of wound and continues to have full weight bearing status with no development of further ulceration. And in the theme of limb salvage and wound care, lest we forget plastic flaps in aid of correcting non-healing ulcerations. And this was a scenario wherein we did a rotational flap, so I thought that that would be interesting to throw in here. And then in the donor site to the flap, we placed a cadaveric allograft. Thank you very much.
Next lecturer is Paris Payton. She is a PGY2 resident from St. Vincent Charity, Cleveland, Ohio.
Okay. Okay, yes, my name is Paris Payton. I'm a second-year resident at St. Vincent Charity Medical Center in Cleveland, Ohio. And I'm going to be presenting a case about a subcutaneous hematoma that presented at our hospital. So a 58-year-old male presents to our emergency department complaining of a progressive, painful, swollen right leg for the past 4 days. He states that his symptoms started shortly after he struck his leg on his vehicle while exiting. And he states that he didn't really feel like he needed to come in at that time. However, he decided to come to the ED after noticing that the pain had increased and the swelling was becoming very uncontrolled. So the patient has a past medical history of end-stage renal disease. He's on hemodialysis, COPD, hypertension, and the patient's also had a AAA in the past with repair. His meds are listed below. He has no known drug allergies. He denies all social history, and his review of systems was largely unremarkable. Physical examination, he was neurovascularly intact. He did have significant non-pitting edema appreciated to that right lower extremity. There were no focal increases in skin temperature noted. He also didn't have any clinical signs of infection. But as you can note on these photos that I've included, he did have a significant difference between his calf size. His right limb was 51 centimeters as compared to the left calf, which was 37.5 centimeters. And he did have significant palpatory tenderness on the right. So on dermatologic exam, the patient has a partial thickness wound. He did have some sanguineous drainage noted there with an underlying firm mass that measured approximately 15 centimeters in diameter. There was also a large area of eschar to the medial leg with multiple serous fluid-filled blisters surrounding. There wasn't any periwound erythema, and the skin was very taut, and there was no underlying fluctuance that was noted. So he is vitally stable. As you can see, his labs are fairly normal for his past medical history. He has some elevation in his inflammatory markers, but that's pretty consistent with end-stage renal disease. The most concerning thing for us was that he did have a significant drop in his hemoglobin level. So it was only 7.5, so we're very concerned for any acute blood loss at that time. So we just skipped plain film radiographs just based on our clinical suspicion. We jumped right to a CT scan. Although MRI is typically indicated for evaluation of soft tissue masses, we felt that a CT would provide more valuable complementary information to better characterize this mass. So on this axial slice, you can see there's diffuse soft tissue edema and that large homogeneous intermediate density mass, and it's involving both the anterior and lateral compartments of the limb. Unfortunately, there wasn't any osseous involvement. There were no calcifications within the mass, no septations or lobulations, but you can note that there's significant impingement to the surrounding skin as well as the underlying musculature. This is just a sagittal slice. Again, you can just appreciate how large that mass is involving that lateral compartment and impinging on that skin. You can see that it's very thin there and that underlying musculature. So our assessment at that time, based off of our imaging and just clinical examination, is subcutaneous hematoma. He also had that partial thickness wound, and he's in stage renal and hemodialysis. We plan to just admit the patient and take him fairly emergently to the operating room for hematoma evacuation. We also transfused 2 units of blood at that time, and we started some prophylactic IV ANSEF just to prevent any infection from developing. So these are some intraoperative photos. A vertical incision was made overlying the mass, and a hematoma was completely evacuated. It was approximately 800 cc's of coagulated blood in the area. We did utilize pulse lavage. We took pre and post lavage cultures, and at that time, I mean, looking at his soft tissue at that time, we decided to allow the tissue to demarcate for a few days and then take the patient back to the operating room for a definitive debridement. So just on post-op day 1, you can note that there's significant necrosis and dysvitalization to the overlying skin flaps as well as the underlying subcutaneous fat. He had quite a bit of fat necrosis noted. However, the wound did not probe down to bone. There wasn't any exposed musculature, so that was pretty good for that patient, but we knew that we were going to have to resect a lot of this tissue. And also notable on his dermatologic exam, he has a lot of just really not healthy skin, so we knew that this was going to be a very challenging case in getting this wound healed. These are his postoperative x-rays. They do demonstrate a significant improvement to his soft tissue envelope. However, there is still that large soft tissue defect laterally. But again, no osseous involvement. He's very fortunate of that. So his pre-lavage cultures did grow back bacillus as well as coag-negative staph species. However, his post-lavage cultures did not grow anything. We just decided to keep the patient on IV Ancef prophylactically at that time. And in this case, we are left with a very large soft tissue defect in a renally compromised patient, and that can present a lot of challenges as they do have impaired wound healing. I was fortunate enough to have the opportunity to co-author a chapter recently on the perioperative management of renal patients, and I just wanted to include some of the literature I found in regards to the findings confirming impaired wound healing in these patients. So most of the literature is animal models demonstrating delayed wound healing in a uremic state. That's secondary to disruption of fibroblast proliferation, delayed rate of granulation, abnormal collagen production, as well as just an overall low rate of vascularization and cell proliferation. And there's human research that also supports these findings in CKD patients. There's specific CKD factors that do put them at risk for delayed wound healing, including a chronic inflammatory state of their system. Most of these patients are malnutrition. They do have a level of malnutrition. There's also electrolyte abnormalities and big challenges of fluid retention that we run into in wound healing. Another thing to note is very important in renal patients is that they do have some element of peripheral arterial disease. The literature states that vascular insufficiency is 3 times more prevalent in these patients, and the severity of PAD does worsen with the increasing severity of CKD. So, as I mentioned before, we plan to take the patient back to the operating room for that excisional debridement with the application of negative pressure wound therapy. We are also working to optimize the patient's nutrition utilizing supplementation while he was in-house and then giving him prescriptions outpatient. And we also wanted to get a good evaluation of his blood flow at that time for his healing potential. So we obtained some non-invasive vascular studies as well as consulted vascular for a definitive angiogram. So these are his ABI results. As you can see, there's no significant drops between the segments. Unfortunately, his ABIs were not terrible. They're pretty much within normal ranges. And his waveforms are normal with a preservation of that dicrotic notch. The patient did ultimately get an angiogram. As you can see, he does have 3-vessel runoff and no intervention was indicated at that time. So this is the patient 2 weeks postoperatively. He's had a wound vac for approximately 2 weeks. You can appreciate the size and depth of this wound after that excisional debridement. But the wound is largely fibrogranular at this stage, but it is starting to come around. This is a patient after 4 weeks. The wound has less depth and it's definitely more granular in appearance. We're continuing with the negative pressure wound therapy. After hearing Dr. Botek's lecture in regards to negative pressure wound therapy, we probably could have utilized some more novel techniques to shorten his healing time, but he was progressing well with just the electric modality. So this is the patient at 2.5 months. Again, he's been having that negative pressure wound therapy and local wound care weekly. He did have significant progress with a nice granular wound bed. The wound at this point is almost completely filled in. And this is the patient at 3 months. We decided at this point he's ready for skin grafting just to provide coverage. This wound looks excellent. So we're taking the patient back to the operating room for a debridement as well as the application of a human skin allograft that we've had great success with in the past for that wound coverage. And we also were continuing to implement pretty significant compression therapy with him just to control his fluctuating edema levels. This is a patient at 4.5 months. You can see that graft application has taken well, it's been pretty successful. You see a lot of epithelialization to the wound periphery, and there's been a significant decrease in the wound size overall. This is the patient at 5 months. Again, the wound graft incorporation is excellent, and the wound continues to shrink. And the patient did undergo multiple applications of this graft, and you can see him at 5.5 months. At 6 months, almost completely healed. This is just a slide showing the progression of this patient from initial presentation through complete filling in of his soft tissue defect and grafting paired with local wound care. And this is at 10 months. This is how the area looked. The patient was completely healed at 8 months. However, we are very pleased, and he was also very pleased with his result with the remodeling of that skin graft. Thank you.
Next resident will be Preston Panico. He's a PGY3 resident at St. Vincent Charity in Cleveland as well.
Paris, how do I get full screen?
The next one over, yeah.
This
That one.
Yep.
This one right there, yeah.
All right. Good afternoon. This was an interesting case that I came across as a first-year resident on my internal medicine rotation. So we have a 69-year-old male with a left fifth digit wound that has been present for the past 6 weeks. This has resulted from shoe pressure. Patient states he has recently noticed some swelling and drainage and was treated with oral antibiotics. He denies constitutional symptoms. His past medical history is significant for type 2 diabetes, hypertension, hyperlipidemia, and chronic kidney disease, as well as mitral valve regurgitation. Denies any past surgical history. His meds are listed below, and he is a former smoker. On physical exam, patient is seen to have biphasic pulses to the right foot, as well as a monophasic DP and PT to the left with a non-Dopplerable perforating perineal. The skin temperature is warm to cool with no focal increase or edema present. Light touch sensation is intact, and as you can see from the picture, the patient does have this full thickness wound. It has some mild purulence as well as mild malodor with no erythema. His labs, his ESR was slightly elevated at 53. However, what you can see here is A1C is significantly elevated at 12.1. We wanted to get some imaging studies. You can appreciate osteolytic changes to the head of the proximal phalanx on the AP radiograph, as well as obliteration of the middle phalanx. You can also appreciate some calcifications overlying the dorsal aspect of the foot on the lateral view. We did get non-invasives. There is some decrease in segmental pressures, as well as mild loss of the dichrotic notch. Next, we did consult with the vascular surgeon. They did perform an angiogram. On the left, you can see the stenosis of the AT. Following the angiogram, all 3 vessels were patent. So this is a picture. Following the angiogram, we did take a culture swab, and it did come back for MRSA. So our plan at this time, we wanted to get this left fifth digit amputated. We wanted to resolve this bone infection with 6 weeks of IV antibiotics so the patient could come back and have his mitral valve replaced. The fifth digit amputation went over well with no complications. Here he is. Here's a picture 3 months from his amputation. However, following the patient's mitral valve replacement, we did get consulted to this patient. Once again, he reported having 10 out of 10 sharp pain to his bilateral lower extremities. Again, here's his past medical history. Now this time on the physical exam, the DP and PP pulses were monophasic bilaterally, and the posterior tibia was non-Dopplerable bilaterally. The CFT was absent to the digits, and the skin temperature is warm to cold from proximal to distal. Neuro, the light touch and protective sensation were absent distal to the midfoot bilaterally. As you can appreciate on the picture to the right, he does have some modeling of the plantar skin, which I'll show you in the next slide, as well as a serous blister dorsally. No open wounds. Musculoskeletal exam revealed absent range of motion of the distal digits, and his muscle strength was severely diminished to the lower extremity compartment, secondary to excruciating pain. Here's these pictures. You can see the blister on the dorsolateral right foot, as well as the modeling in the plantar skin with some necrotic changes to the digits. Patient also had necrotic changes to his digits in his hand, which were later amputated by a plastic surgeon. So we are following this patient very closely in-house. And as you can see, his white blood count has skyrocketed to 21.6. All his inflammatory labs are elevated, and his H&H has dropped to 6.7 and 27.7. Some differential diagnoses are listed below that we are trying to see what this patient was dealing with. So our plan, we worked with Vascular. We wanted to apply nitroglycerin patches, reverse Trendelenburg, warm blankets, and a vasodilator. And the vascular surgeon's plan was a bilateral transtibial amputation. Here's the patient status post bilateral BKA. So how did this event occur? So this patient was suffering from heparin-induced thrombocytopenia. Here's some general background and some studies that you can do to help confirm or deny this diagnosis. HIT is caused by a formation of abnormal antibodies that activate platelets. The immune system forms antibodies against heparin when bound to proteins, specifically platelet factor 4. Most common symptoms include enlargement of previous blood clot or development of a new blood clot elsewhere in the body. Some laboratory tests that I'll speak of soon. The treatment is cessation of heparin, in addition to an alternative anticoagulant to suppress the thrombotic tendencies. Some background, type 1 and type 2. Type 1 is a non-immune disorder which occurs from a direct effect of heparin on platelet activation. It's usually present within the first 2 days, and the platelet count does normalize. Our patient was dealing with type 2, which is an immune-mediated disorder. This occurs 4 to 10 days post-exposure of heparin. And as you can see with this case, it does have limb and life-threatening thrombotic complications. The 4T score, it's a clinical score that can help confirm or deny the diagnosis of HIT. So our patient had a fall in platelets greater than 50%. This happened about a week after the commencement of heparin. As you can see from the pictures previously, it did have skin necrosis, and there could have been possible alternative cause. So our patient had a HIT 4T score of 7, anywhere from 5 to 8. It's about a 50% chance of the diagnosis of a HIT. A couple of tests that you can run are the Eliza Tests. This is the most common test used for HIT. This detects all circulating antibodies binding to heparin, PF4 complexes. However, this does have a high false positive rate. Another one that you can run, this is the gold standard. It's a serotonin release assay. A couple of negatives to this test. It's very expensive, and it takes about a week to get back. This test, platelets are washed with serum and heparin. A sample is tested, and if serotonin is released at a high level, you have a diagnosis of HIT. Thank you.
Next resident. Amanda Peugeot is going to lecture, and she is from, actually she was at the Cleveland Clinic, and now she's a PGY2 in Oklahoma City. Is that right?
Yes, it's a conjoined program. If I can get it to work. Hi, I'm Amanda. I'm going to be talking today about a successful attempt in limb salvage in a Charcot foot. So a 52-year-old male with a past medical history of diabetes with neuropathy, hypertension, cardiac disease, no known drug allergies, no trauma history, is currently a forklift operator at a Lowe's and lives with his sister, presents with progressive swelling and discoloration for about 1 week. He came in at the urging of his sister due to the size of his foot. He complains of no pain and wants to continue to work as he continued to work during this time. History of multiple episodes of non-painful swelling and discoloration over the past year, and then 2 episodes of sinus tract development and drainage over the past year. This is information from his sister. You can see the difference in size of the ankle between the affected and non-affected ankles. Remember that, so whenever he came in, podiatry was consulted 4 days afterwards. So these pictures are actually taken 4 days after he had been admitted with bed rest, elevation, and compressive dressings. This area is where he had the previous sinus tracts and drainage. He had palpable pulses but diminished protective sensation because he's neuropathic. So initial foot films, you can see significant destruction of the entire greater and lesser tarsi. On the lateral foot films, you can notice that the talus had also been pushed down into the middle of the foot. Ankle films, the only things which are normal or you can appreciate are the metatarsals, the calcaneus, and the tib fib. General architecture is pretty good with the exception of the distal calcaneus, but overall the alignment with the tib fib and calcaneus is pretty aligned. So since he had swelling, an ultrasound was conducted. It was normal. White count was normal. ESR and CRP was slightly elevated, and uric acid was within normal limits. But admission, they admitted him for osteo and cellulitis. The patient was also afebrile, denied any nausea, vomiting, fever, chills, or any changes in appetite, and so they admitted him for antibiotics and bed rest, compression dressing, and then consulted podiatry at that point. So CT scan was done, and you can see the fragmentation in the bones. More fragmentation. Destruction noted. You can appreciate geodes in the bone in almost every cut. It's just like formations in every bone. So based on the severity of the deformity, the patient was referred or given the option of an amputation. The provider had a long, lengthy discussion about a possible BKA versus limb salvage, and a good option would be that BKA to provide a more stable ambulatory limb, less recovery time as compared to the extensive limb salvage procedure, but the patient refused and wanted to proceed with the limb salvage procedure. So now what? He wanted to proceed. But before we could proceed, we had a cardiac consult done due to him having abnormal heart sounds on S3 and S4. A pre-op echocardiogram was also done, but no significance was found. So now we're 6 weeks out after admission and cardiac clearance. You can notice the outline of the talus is better appreciated on both AP and lateral foot films. Less edema due to him being compressed and elevated. So the plan was to extirpate the talus and then perform a tibiocalcaneal fusion. But while in the operating room, a significant amount of fluid was experienced, about 40 to 50 cc's of thickly hemorrhagic fluid. Again, remember that the patient had been non-weight bearing for about 6 weeks. So then at this point, our plan kind of changed. Disregarding the fusion at this time, deep and superficial tissue cultures of bone and soft tissue were then taken, and the patient was admitted to the hospital for antibiotics and for delayed primary closure, depending on the results of the cultures. So intraop cultures, superficial, you had staph and Pseudomonas. Deep soft tissue cultures were negative. The talus did have staph and Pseudomonas as well, and then deep bone was negative. And at this point, the patient had been off antibiotics for at least the 6 weeks. So surgery number 2, this is a week later. We wanted to apply an X-fix after debridement of 15 liters of lavage and then do delayed primary closure. He was treated while in the hospital for antibiotics for about that week. A drain was placed for the dead space, and management of distraction was obtained to maintain length, even though the chance of utilizing a bone graft at this time clinical situation was very unlikely. And then the patient was then discharged on antibiotics. So for surgery number 3, approximately 3 weeks later, the patient returned. At that time, he had that multiple washouts before, and then at this time, antibiotic spacer was placed. The patient returns again, this is status post, 12 weeks from the initial talectomy, to have the spacer removed and again delayed primary closure with a debridement and washout. So local antibiosis, a article by Osterman et al. At JBJS talked about 1,085 open fractures in 914 patients and the use of PMMA antibiotic beads. He had two groups, so 240 patients used systemic antibiotics only, and then group 2 had 845 patients that also utilized the PMM beads. Overall infection rate was 12% in group 1, but with the utilization of the PMM beads in group 2, it was only 3.7%. So this is the final reconstruction. This is post-op week 18 from the original surgery. At this point, all cultures were negative from the previous surgery where the spacers were removed. The patient managed to be on a standard perioperative antibiotic protocol with respect to the fusion with any changes needed if clinically warranted. So the key to note about this is that for this arthrodesis, we want to make sure that the superior surface of the calcaneus is fashioned for reciprocal fit with respect to the tibia. Positioning of the tibia on the calcaneus is facilitated by reciprocal cuts of the tibia and calcaneus, and that allowing the calcaneus to slide anterior and posterior as necessary. So for this procedure, we wanted to use a vascularized fibular graft, and the technique for this allows the vascularized fibular onlay bone graft to enhance a bone healing potential and also as well as structural and vascular support for the fusion site. So the procedure for this, you use the initial syndesmotic dissection, proximal fibular segment removal, careful fibular distraction and rotation, sagittal fibular split with medial removal, perform the arthrodesis, then you prepare the lateral fusion site, replace the fibula, suture the deep fascia, and then fibular fixation screw versus plate. So I didn't have intraoperative pictures from our actual case, so I'm going to go into this quick case in which the fibular onlay graft was utilized. So this is an example of a 26-year-old who had an open talar neck fracture, sent back to follow up with the orthopedist, and 6 months later, you can see the post-injury x-rays. So you use a bovie to utilize and incise the syndesmosis first, and then a section of the fibula was then removed and the fibula was separated from the tibia with care to maintain posterior soft tissue structures for posterior lateral rotation of the fibula. Most importantly, all soft tissue is left on the lateral fibula, and this allows the vascularization of the bone graft. So looking from distal to proximal, you can see the saw blade and the sagittal osteotomy of the fibula on the left picture, and then this creates, on the bottom right, creates a medial 1/3, lateral 2/3 segments of the fibula. So the medial portion was then removed, and the lateral portion is then rotated posterior laterally to perform in the main process of the tibiotalar or the tibiocalcaneal fusion. So this is when the talar fusion was completed. The vascularized fibular graft is replaced over the lateral fusion site and fixated with an interfrac screw, but it's now recommended that you can use a contoured fibular plate for greater stability of the fusion complex. So these are the pre-op x-rays you can see again, and then the post-op x-rays with the status post-pantalar fusion. But going back to our own case, so the patient is now post-op week 18 from the original surgery. We take them back and we do a primary tibial calcaneal fusion with the fibular onlay graft and the plate to secure it. This is 5 weeks after this final reconstruction. He is currently non-weight bearing at this time. He has good alignment and the maintained hardware is intact. He's post-op week 13 here. The bones are consolidating. You can see trabeculation is appreciated over the fusion site. He's now 7 months post-op, still has good alignment, fused. Radiographically, the fusion sites look like they're fused and aligned. So he's 9 months post-op. He now has this planar grade embraceable lower extremity. It was a long journey for him, but he did elect to go for this procedure, and he knew that it's a time-consuming procedure, but at the end result, if it does go well, you do have a functional limb. Thank you.
Our next speaker is Ashley Mariano. She is a third-year student at Kent State University College of Podiatry Medicine.
I'm so short.
Let me see if I have the right thing. Yeah, okay. I'm super short. Okay, hello everybody. Like Dr. Shook said, I'm Ashley Mariano and I'm a third-year podiatric medical student attending KSU CPM. Today I'm presenting a case on necrotizing fasciitis that Dr. Jeffrey Shook provided to me. So a 53-year-old male came into the emergency department weighing 210 pounds at 5'9". He came into a small 70-bed hospital because his brother, who happened to be an EMS worker, forced him to as the patient wasn't feeling well. His body mass index is 31, which classifies this patient as obese. The plantar aspect of his right foot presents with an ulcer submetatarsal head 1, measuring approximately 1.5 centimeters in diameter with a full thickness depth to the first metatarsal bone and joint. The likely portal of entry of this infection was this neuropathic ulcer that began as a pressure point callus. According to the Wi-Fi classification, this ulcer is classified as stage 4, which is a high risk of amputation. It's also important to note that the pulses were palpable prior to any surgical procedures and the patient had normal tissue perfusion. This is the patient's dorsum of the foot on the same day. There are large hemorrhagic bullae surrounded by red inflamed and necrotic tissue. Crepitus was palpated on the dorsum of the foot all the way anteriorly to the distal 2/3 of the leg. The patient has had an infection for a while as he has progressed past those first signs of necrotizing fasciitis to a more severe stage. This patient is an undiagnosed, uncontrolled diabetic who has not seen a doctor in 33 years. He had profound neuropathy that initially he had no pain or sensation with the plantar aspect of his foot, and then about 4 to 5 days ago, he started to feel ill and he had pain to the right extremity. So this patient's blood pressure upon entering the emergency department was 220 over 110, and he had some concerns for renal and cardiac dysfunction. So other lab tests were ordered, such as an EKG, which was unremarkable. His hemoglobin and hematocrit were also normal. Other tests included a BMP and a CBC with differential. He did have some elevated creatinine at 2.0 milligrams per deciliter, and his C-reactive protein was extremely elevated at 13 milligrams per liter. Radiographs were also taken. I don't have the radiographs, but it did show evidence of soft tissue gas in the dorsum of the foot. So this patient demonstrated signs and symptoms of systemic infection, which included nausea, anorexia, fever, and chills. And he did have at least 2 clinical signs of SIRS, which included the elevated white blood cell count and the fever. According to the SIRS criteria, this patient was in sepsis, as he did have a confirmed source of infection. Treatment for SIRS usually is to treat the underlying pathology. In this case, this patient was rapidly given antibiotics, supportive therapy, and surgical intervention. General surgery was the first to see this patient in the emergency department, and then he consulted the foot and ankle specialist from the hospital, which happened to be Dr. Shook. Both doctors recommended the BKA, but this patient was kind of hesitant on it. But after some careful consideration, they decided to go with the limb salvage procedure because the patient was 53 and he did have a job that worked 40 hours a week. So, they also took into consideration that more proximal amputations have a higher mortality rate and greater energy expenditure. Other consultations included anesthesiology, infectious disease, and critical care. Anesthesiology urgently put in a central line to administer these empirical antibiotics. According to the IDSA clinical practice guidelines, most diabetic foot infections are polymicrobial in nature, so that's why broad-spectrum antibiotics are indicated. So They administered penicillin G, vancomycin, and Zosyn. And the patient was on these IV antibiotics for 7 days while he remained in the hospital and while undergoing multiple surgical procedures. So the primary objective of the initial surgery was to reduce that bacterial load, performing an incision and drainage with extensive debridement. The incision first was put on the top of the foot, and it was in order to express all that purulent, foul odor material. All necrotic tissue was debrided until healthy dermal bleeding was seen. A transmetatarsal amputation was performed to remove all that deep necrotic tissue and infection. And since most of the forefoot was infected, a residual plantar flap was not able to be saved for the closure of the wound. So the area was actually left open. And during this first surgery, a post-debridement specimens were collected in multiple locations and cultured. After about 3 to 4 days, the culture came back positive for methicillin-sensitive Staphylococcus aureus and E. coli. So the patient's symptoms actually responded quite rapidly to the first surgery with a significant pain reduction in the first 24 hours, and as well all signs of sepsis resolved, which included initial drop in white blood cell count from 40,000 to 20,000. So in the second surgery, further debridement and amputation was necessary. Lesser tarsal amputation included the distal aspect of the cuboid and as well the distal aspect of the cuneiform, preserving the navicular bone. The goal, as all of you know, of a limb salvage procedure is to make a stable and plantigrade foot. Therefore, the extensor hallucis longus tendon was resected to a healthy level, and it was tagged with non-absorbable suture for future harvesting and tendon procedures. The anterior tibialis, the perineal tendons, and the EDLs were all compromised in the infection. So the extensor hallucis longus tendon, it was used for tendon balancing and for the foot in the front, from front to back in the sagittal plane. And basically, it prevents equinovarus deformity so you don't get that reinfection and reulceration, because that could lead to even more further proximal amputations. The extensor hallucis longus tendon was fixated into the lateral aspect of the navicular bone using a biotendesis screw fixation. And the gastrocnemius tendon was lengthened in order to lower the pressure at that frontal residual stump and improve future ambulation. So to promote wound healing, the Integra Bilayer matrix wound dressing was applied to the wound. There are two important layers to this product. There's that superficial layer, semi-permeable silicone to help with barrier for bacteria, as well as to prevent water loss. And then underneath, we have the collagen and glycosaminoglycan matrix that helps as a scaffold for new vessel growth and protein for skin regeneration. And to prevent nosocomial infections, this patient was discharged after 1 week of being in the hospital. The wound was temporized with the graft, and the patient was sent home with oral augmentin and ciprofloxacin. I also want to note that the patient did see an endocrinologist to treat the hyperglycemia when he was in the hospital. So after 3 weeks, that superficial layer was removed, and there was clear evidence of wound healing, as you see with the granulated wound bed, as well as the decreased urethemia and decreased edema. And then for the definitive surgery, a split-thickness skin graft was applied to the wound. As you know, the split-thickness skin graft is an epidermis layer with partial dermis, and it was replacing the silicone membrane that was removed. And the split-thickness skin graft was removed from the patient's calf. And the skin graft eventually created a smooth surface of regenerated skin, but as you can see, there is a little bit of distal necrosis, so there was a little bit of failure of the skin graft. So during post-operative week number 6, a revisional surgical procedure had to be completed to remove all that necrotic tissue until healthy dermal bleeding was seen. And finally, there is a happy ending to a very complicated but successful limb salvage procedure. The patient survived a very serious and life-threatening infection. The doctors were able to prevent that BKA and basically help the patient in the future. And as well, the patient now ambulates with an ankle foot orthoses and tennis shoes, and he was able to go back to work eventually and actually have a functional life. And that's it.
All right, cool. I'm Belinda. I'm one of the third-year residents over the Denver VA. I'm not good at having clever titles. So this is Mr. K. Mr. K is a 56-year-old diabetic male. He presented to the ED beginning of March. He was sent to the ED because his home health nurse presented and called his family concerned about his status. She said when she walked in that he was having emesis and he was having active diarrhea and there's diarrhea all over the floor. Pleasant. So he had his family bring him to the emergency department. The patient stated he'd been feeling ill for about the past 4 to 5 days. He said he had an upset stomach, headache, progressed to vomiting and diarrhea. He does admit to bilateral foot pain since Friday, which is strange because he is neuropathic. He does have pretty bad vision, so he couldn't tell what was going on with his feet, couldn't visualize it. But he denies any history of trauma, wound, or any thermal injury, though he does have a space heater. He says he doesn't put his feet by it, but who knows? Admits to abdominal pain, calf pain, chills, nausea, and vomiting, but no fever. Past medical history noted here. Past surgical history of note, he is a vascular patient. He's seen vascular in the past, status post right PT, AT, and perineal PVI. Current tobacco use as well, and history of previous amputations due to osteomyelitis. Meds listed there, allergies there. Vitals, nothing that screams to us right now, sir. So nothing too alarming at this point. The lower extremity, however, once we started examining it vascular-wise, we did note +2 pitting edema to the right leg, +1 to the left. His right digits were severely cool, though his midfoot and the rest of his extremity were warm. The left digits were moderately cool. His gross sensation was diminished, and he deferred any muscular exam, according to the note. So I don't know if there's any sort of crepitus or fluctuance when they were palpating him and whatnot. Oh, it didn't come up. Oh, there we are. Okay, got confused. So derm-wise, we did note he had desquamation and skin sloughing noted to the plantar aspect of his bilateral foot distally. The left foot, he had hyperpigmentation to the forefoot, no obvious defects in the skin, though it was noted that his left, second, and third digits were gangrenous. The right foot extending from about the foot to the low of the ankle, it was kind of a mix of blanchable and non-blanchable erythema. On top of that, it kind of had this like indurated, mild purplish discoloration. Again, no obvious defects in the skin, though a pustule was noted in the third interspace and expressed. Interestingly enough, he did have erythema to the right medial thigh. We didn't think it was streaking because it didn't connect to the foot. He had this erythema from the foot to the ankle, clear space between, or no erythema, between the ankle and the tibial tuberosity. Then he had this erythema. So we made that very clear in our note. To kind of get better visual indication of what was going on here. Here's some images that were taken in the emergency department. You can see on the dorsolateral foot what we were talking about with that erythema, but at the same time, kind of like a mild purplish induration. Desquamation planarly, and then at the digits on the left, you can kind of tell the second and third digit, little gangrenous at the tip. So lab-wise, apologize for the formatting there. What really stood out to us was the white blood cell count. So there you go, one of the STIRS criteria has been met. He has anemia, chronic disease, high sugars, we've seen higher. And the ESR at our facility, once it's 0.00 with an H, that means off the chart. It doesn't give us a number. So we knew his ESR is really high. CRP was over 150. So we got imaging, determined, what was going on underneath. Was there any sort of gas, fracture, or anything going on there? You can see here at the right, he does have that swelling to the right lower extremity. No obvious fractures. He did have that previous surgical intervention there. The left, same thing. He had some swelling, but much more compared on the right. No obvious defects in the skin and whatnot. So the question became, what was going on with this patient? Definitely these patients, you want to have a high suspicion. What we were concerned about after getting a Lernix score of 12 was necrotizing fasciitis. Though it might have been, elevated due to the fact that he is a renal patient, we decided with the Lernix score of 12, let's do a bedside IND, make sure that there isn't any abscess or underlying source of infections, which we didn't find. There was some serous fluid expressed, some purulence, but no obvious abscess. There wasn't any foul odor. There wasn't any separating of the tissue planes and whatnot. but with a Lernix score of 8, has a 94% positive predictive value for necrotizing fasciitis, so we decided to admit the patient there. Again, we're more concerned now just for an underlying infection versus necrotizing fasciitis, but always have, a low threshold for admission with these patients, especially since he's well known to the VA. So we took a multidisciplinary approach. We admitted him under medicine due to his comorbidities. Medicine started on broad spectrum antibiotics. We got infectious disease on board to kind of tailor the antibiotics as we progressed through his treatment. We had a vascular consult since he is a vascular patient with previous history of intervention. And we also alerted renal because he was actually supposed to come to the VA the next day to have an AV fistula put in so he can start dialysis. So we let them know it's probably going to be delayed. So we saw him the next morning, and thank goodness we admit him because his clinical picture was a lot worse. This time his skin appeared mottled, dusky, ecchymotic, and this time the tissue was easily divided along the fascial planes with just finger pressure. And then that dishwater brown fluid, malodorous, was coming out. So we thought necrotizing fasciitis, took him to the OR right away, where we did a right foot IND. That top, well, you can't see it yet. That top left picture there is the first initial window that we cut out. That's where he had that initial discoloration. From there, we just kind of progressed. I wasn't in on the surgery, but according to operative notes, same thing. What they did was just run their fingers along the fascial plane until it divided, until the fascia was well adhered. And then you see on the bottom and on the right-hand side, that's the extent that his fascial planes divided. It was noted throughout the procedure, just dishwater, colored fluid, malodorous was just coming out the entire procedure, and the incision to the skin, it didn't have any sort of bleeding whatsoever. So we took him to the OR for that, kept him in the hospital, and rather than belabor you with all the notes that we had him during the mission, kind of had a summary. Again, we took a multidisciplinary approach. Medicine was managing his comorbidities. IND based on the tissue cultures we took in the OR, put him on 2 weeks of zinc and meropenem. All throughout his admission, his white blood cells downtrended. We were able to get renal on board once the patient was stabilized. They got him started on hemodialysis on the 15th. And then vascular, they did an angiography. The patient only had one vessel runoff, where previously, when they had done the revascularization, the PT and the AT and the perineal were patent. Those unfortunately were not, but due to the collateralization from the perineal, they indicated intervention wasn't needed at this time. The patient would be able to heal based on his current blood supply. And so during this time, we wound vac the patient. We didn't do it in the OR, did it while he was inpatient there. The idea was to get that granular tissue over the fascia, because during the procedure, we could see the fascia, we can see the underlying peroneus tertius and EDL tendons underneath that fascia. And then for the gangrene on bilateral digits, bilateral feet, we just kind of let them sit, let them demarcate. Throughout his admission too, he was having some posterior right calf pain. So we got an MRI to rule out any underlying abscess in the deep compartment, which he didn't have. And it's not listed here, but noted that erythema he had to his right thigh, it cleared up with the antibiotics too. So it might have been just something separate from what was going on distally. So on the 27th, it was indicated that his digits had demarcated, so we took him to the OR, did bilateral 2 to 4 amputations of the digits, did a Versajet debridement to the plantar surface of both feet, and at that time in the OR, we applied just the huge epifix and wound vac onto the right lower extremity to kind of help get that granulation tissue in. He was DC'd to a SNF about 2 days later. Since then, we've been following up with him in clinic on a weekly basis, and he just kept progressing, which is always surprising because we had already talked about with him, if this fails, we're looking at a BK, which of course no patient wants. So we were really looking to salvage this limb for him and for us too. So it's a combination of vacuum using different stem cell products. We used the Epicord over his exposed tendons because during his process of healing, there's a couple of setbacks where the tibialis anterior tendon, he just came to clinic one day, we took off the wound vac, it's like, oh, there's your tendon. Same with the Achilles tendon, just because he had been putting pressure on it posteriorly, it was exposed. So combination of grafting and wound vacting has put him to a nice granular bed. So the idea was, okay, get a nice granular base, we consult plastics to hopefully get a split thickness skin graft on him. However, he had a history of smoking, he quit, he picked it up again. So plastics isn't looking to do anything until he ceases smoking, which is totally understandable. But here's some pictures that we just took about 2 days ago when we did a vac change on him. And you can see anteriorly, laterally, and posteriorly, it's still a really big wound. But it's way better compared to what he had initially. So improving by leaps and bounds, like it even surprised me. And in the plastics note, they didn't specify exactly what their plans were other than consider a split thickness skin graft, you know, in the future when patient ceases smoking. So I haven't had much exposure to the plastics. So just looking at this study published in 2018 by Geogene et al. They looked at the different thicknesses of split thickness skin grafts and how it would take, you know, how it increased the rate of epithelialization, pain, and that kind of stuff. So they had adults between the ages of 18 and 17 who were undergoing this transplantation, and they were for a number of etiologies: post-burn, traumatic, or post-op skin defects. They got 84 patients, randomized them into 3 groups: 0.2, 0.3, 0.4 millimeter split thickness skin grafts. Did the conventional therapy where they put a petroleum gauze on top, and then the cotton swabs, moistened cotton swabs with the tire technique to kind of secure it down. They followed them up at 3 days, 1 week, 2 weeks, and 1 month post-op. And these are the parameters that they were looking at. And what they found was that the patients that received the thinner graft at the epithelialization or the recipient site, it epithelialized quicker, statistically significant at 2 weeks. And the same at the donor side, although it's statistically significant at 1 week. And what they determined that only the thickness of the graft was independently associated with wound epithelialization. Pain-wise, they said, and this actually surprised me, but when they talked about it, it made sense. The patients who had received the thinner skin grafts had more pain at the recipient site, and it's because they were receiving a thinner layer of tissue to that site. So it wasn't as much coverage, more pain. And at the donor side, it was what was expected. The thicker graft you take, the more pain they have at that donor site. And this was seen at 3 days, 1 week, and 2 weeks post-op. At 1 month post-op, however, they said a younger patient age was also associated with more pain at the donor site. And this is because with older individuals, decreased perception, so they perceive less pain there. So what they concluded was, you know, if you're going to do a split thickness skin graft on a patient, probably consider the age, probably consider the thickness based on the location and whatnot. And for us, I think it's important to, you know, base it on your patient population too. I like the idea of having a 0.2 millimeter, you know, split thickness skin graft with all those vascular channels there. But at the same time, what I worry about is non-compliance and shear force. The patient's moving around and whatnot. Is that thinner graft more susceptible to failure? And then I looked at this study, also published in 2018 by Yin et al., looking at conventional therapy versus negative pressure wound therapy on a split thickness skin graft. It was a meta-analysis looking at randomized controlled trials and cohort studies. The primary outcome was the rate of graft take. And what they found was negative pressure wound therapy was superior to that of conventional therapy, in that it creates that negative pressure environment for that graft, decreases any seroma or hematoma formation, decreases any sort of shearing forces in that area too. It didn't have an effect on wound infection, however. So I think if I had any say in it with the plastics people, I'd say, let's do a split thickness skin graft. Let's continue with that wound vac therapy and hope he is, compliant in keeping that vac intact. We all know patients somehow accidentally rip the vac off sometimes, which is mind-blowing to me. But no, I have really high hopes for this patient. Like I said, he's well known to podiatry. I've seen him since I was a student there. Hopefully he can cease his smoking, get his blood sugars under control, and then we can get him all healed up. That's it.
Thank you very much. You can.
Yes.
So a very sophisticated case, obviously, from the standpoint of the wound care and all the surgical things you did. Not really my expertise, but you mentioned that you send them for the angiogram and evaluation, and we said that the folks you referred them to told you blood flow was good.
Yeah.
Based on what?
They did an angiogram, and they said that they had a lot of collateralization from his perineals to the tibialis anterior and the tibialis posterior arteries.
Yeah, so that's I'm just trying to make a point, is that, all that work you did is dependent on that one little thing that they told you.
Exactly.
And my point is that, and this is very common. If some of the folks here that know me know that this is my pet peeve, that you guys, because you're doing so much work and you're putting so much energy And you can't just take those words for granted, because that's very subjective. Just collaterals, what are the size of collaterals? I mean, we have other perfusion tools to tell us if the patient is going to wound, is going to heal. So if somebody tells you a straight line flow is occluded, I don't think we should be relying on collateral flow unless you have other objective measures that tells you the blood flow is good. And I don't think you can rely on other people. I really think that as wound care experts, as podiatrists, that are putting so much effort and energy into this, you yourself have to assess the perfusion. So you either have to order TCPO2, in this case, I don't think you could have done a TBI or ABI during the wound, but we could have done a TCPO2 or something, because it's so much stake, to just take their words for it, and when you're doing so much.
Yeah, no, definitely. I think if we hadn't seen that improvement in his wound, we would have gone back to Vas and said, hey, is there anything else we can do for this? I know we have these collaterals, but the wound isn't improving. But luckily for us, he improved.
That was a great case.
Yeah, thank you.
The last presenter, Dr. Andrew Yang, second year here at PSL.
Oh, here's your USB. That's not hers. Oh, oops.
Yeah, that's.
Oh. Hi, I'm a second year at PSL. Thanks for having me here, and welcome to Denver for whoever's not from here. So my case, I'm not going to tell you guys what it is, because it's not one of the cases like where the other past residents or students were doing, where they're big recon cases. It was more of a case about a clinical diagnosis that we weren't really sure what it was in the beginning. So to start off with, chief complaint is a pain and redness to the right foot. So this is a 48-year-old male, history of diabetes type 2, end-stage renal disease, status post-kidney transplant in 2013, bilateral TMAs, and he was admitted for a pain and erythema of his right dorsal medial foot. The patient was previously seen by attending, and he was prescribed PO, Doxy, and Levo for the past week, but it did not improve. He had increased pain, increased erythema, so he was admitted to the hospital for further evaluation and IV antibiotics. Denied seeing any fevers, chills, nausea, vomiting, any open ulcerations or purulent discharge or any trauma. His past medical history, prevalence, diabetes, hypertension, status post-kidney transplant, huge list of medications. He's on immunosuppressants. He had a past history of limb salvage, where he had multiple ulcerations for his digits on his right foot and his left foot, and then that resulted in getting a TMA. He used to be a smoker, but he quit about 7 years ago. Currently, occasional alcohol smoker. His family history is on here. So his vitals, he was afibral, and his vital signs were stable. His vascular, he was DP and PT are palpable. He had some edema to the right medial foot, loss of protective sensation. He had no open wounds on his right foot, but he had some erythema and edema noted to the dorsal medial aspect of the right foot, and he status post TMA bilaterally. His labs were pretty unimpressive. His chem panels here, he didn't have a white count, but he was also immunosuppressed. And he recently got an A1C at the time. The A1C was 7.6, so he's a pretty well-controlled diabetic. And here's his radiographs at the time. As you can see, he had no cortical erosions along the dorsal medial aspect of his foot, no signs of trauma, no subcutaneous gas in lateral x-ray, but you can see some soft tissue swelling on the anterior aspect of his foot and dorsally. At this time, I didn't have any clinical images of the foot, because this was his initial admission, which was in 2015. And when I saw him towards the end of 2017, he just got a new phone, and so he deleted all his pictures. Yeah, and so this is the official read from the radiologist, negative for acute osteo and some soft tissue edema. And here's the MRI of his right foot. You can see some increased signal intensity along the dorsal aspect of his right foot, nothing in his bones to suggest osteomyelitis. And they said there was a possible ill-defined fluid collection along the dorsal aspect of his foot, but I couldn't really appreciate it myself. And this was the official read. So at the time, the assessment was cellulitis and abscess of his right foot. IR did a drainage of this ill-defined fluid collection. They had negative cultures. So they kept them admitted. It took away the antibiotics just because the cultures were negative. They monitored him for about 3 days, and then the erythema and the pain improved, so the patient was discharged. About 2 days later, the patient came back for worsening erythema and edema around the dorsal medial aspect of his foot with new bullae at the right dorsal foot. Again, no fevers, nausea, vomiting, but he had some chills this time. He was afebrile, his vital signs were stable. His white cell count was 6.6, and lactic acid was 1.02. So they thought it was possible recurrent cellulitis, stasis dermatitis versus some kind of trauma, Charcot or hematoma, and they started back him on IV vancomycin. So this time they took him back to do an IND for more definitive cultures and deeper cultures. No purulent fluid, negative cultures. Again, due to this erythema and the negative cultures, they took him off antibiotics and monitored him for another week, and it improved. But this patient, due to his past history of multiple amputations, he was really concerned about getting further amputations. He was really adamant about getting discharged home with IV vancomycin, otherwise he wouldn't go home. So, per the patient's request, infectious disease discharged the patient home with 2 weeks of IV vancomycin to his past history of MRSA. And then he came back 2 weeks later, basically for the same exact issue, but at this time he also went to multiple other hospitals for consultations. He went to one hospital, they put him on ertapenem along with IV vanco, and then he went to another hospital, and they just discharged him within 24 hours because they said, you're already on whatever appropriate treatment. So after he was discharged from there, he came back to PSL right afterwards. So at this time, they thought that his erythema and edema, and he had some eschar on the dorsal aspect of his foot. They thought it was possibly due his pain and erythema and edema wasn't really infectious in nature, and they thought it was possibly secondary to neuropathic pain or atypical VZV. So they discharged him again on PO, Clinda, and Levo this time, and started him on gabapentin just because the patient wanted to go home on antibiotics, even though no one expected a source of infection at all. And then this time, he came back 4 weeks again with some new bullae formation while on PO, Clinda, and Levo. And he has this, he had a chronic recurrent atypical inflammation on the right foot that improved on broad spectrum IV antibiotics. So at this time, everyone was really confused what was happening. No one really knew what was going on. And even though it improved with IV antibiotics, they still didn't think it was an infection. So they consulted derm for punch biopsy. So they did a punch biopsy over the bullae and sent it out for pathology, for H&E and direct immunofluorescence. And this is the first clinical image I was able to get. This was in 2017 when I saw him on his right foot. This is his right foot with all the previous bullae formations and the eschar and the scabbing and the scarring. And this is his left foot. And this is the pathology result from biopsy. So you got subcorneal intraepidermal bullae formed with hemorrhage and serum collections. Bullae contained some neutrophils, some histiocytes. No signs of vasculitis or thrombi, and more importantly, his inflammatory markers were all negative: IgG, IgA, IgM, C3, and fibrin. So does anyone have maybe a guess what you guys think it could be? It's kind of a weird, rare condition. All right. So I wasn't able to get the pathology slides through some complications. The lab wouldn't release them to me unless I got a consent signed, and the person moved to out of state to the West Coast, and I tried calling him for 2 weeks and didn't get an answer. So he had bullosis diabeticorum. It's a pretty rare condition that happens in about 0.5% of diabetics. It's believed to be underreported just because bullosis diabeticorum is a self-limiting condition, and for the most part, people just get it and it goes away, and they typically don't go to the doctors. The etiology is unknown. It's thought to be related to microangiopathy, neuropathy, microtrauma, so decreased blood flow to the area. Neuropathy, they get some microtrauma they don't know, and some thinning the skin, drying the skin. But then with this theory, why don't all diabetics get it? So no one really knows. At this time, there's no treatment except local wound care for infection prevention. So from 2015 to 2018, he was readmitted 2 or 3 times every year for this issue. And every time he would come, every single time he started having some deep pain in his ankle and his foot. And then we started on IV vancomycin for 2 or 3 days, and his pain would go away. And so he kept on coming back for 2 or 3 years, 2 or 3 times a year, every time for 2 or 3 years, and so he's finally gone now. So that was just an interesting case. So yeah. So the thing I took from this case is sometimes when you have these patients that are really difficult and they come in all the time, you kind of think they're kind of crazy because they're saying they have all these weird pains. Sometimes they may have some kind of weird, rare condition like this guy. So if you have this atypical erythema that just keeps on happening, or these bullae, consider getting maybe like a biopsy sooner instead of letting him thinking that's like no one knows what's going on and just putting him on these random IV antibiotics all the time. So that's it.
Thank you very much. So what we'll do, the judges are going to tabulate the scores, and they'll give you the final result, and then I'll meet with the winner and split the check. Dr. Shibuya is going to come up and continue our afternoon schedule, and he's going to talk about diabetic bone healing.
All right, thanks. So a lot of reconstructive surgery. So let's talk about some bone this time. Got kind of a lot of wound talk this morning, so let's switch your gear a little bit and it'll refresh ourselves by talking about the bone. Same disclosure. So diabetic healing is obviously more difficult when you compare to non-diabetic cohorts. This is, one of the things that you could get a lot of data from is ankle fractures. And if you look at all the ankle fracture study that compare diabetic versus non-diabetic patients, and when you tally all those data, then they're about 5 times as likely to get some kind of complications if you're diabetic when you compare it with those non-diabetic ankle fractures. But when you're talking about complications after ankle fractures, there could be a short-term, acute complications like skin healing complications or the infection and something that happens within 30 days type of stuff. And when you look at those, and about 1 in 4 develops the infection after ankle fractures if you're diabetic. But there's also a long-term complications like bone healing complications or Charcot. In this case, again, if I tally all those numbers, it's like 1 in 5 gets Charcot arthropathy after diabetes, including every diabetes. But this is really just tallying all those numbers out there, and I really wanted to know what in diabetes that's so unique that makes the bone healing so difficult. And so what I did in my institution was to kind of take those people who had bone healing complications and those people who didn't have bone healing complications, they're all diabetic patients, and try to divide it into those 2 groups and see what factors are really independently associated with the bone healing complications. Bone healing complications, in this case, we defined it as a malunion or a non-union or a delayed union, osteolysis or Charcot deformity. So all these clinically relevant factors we included and see what kind of things are within the diabetic population are associated with the bone healing complications. So we found 270 cases from our institution, the mean age was 62, more female patients. And there's several factors that are associated when you just do that, one-to-one comparison, like a bivariate analysis. But some of the factors interrelated to each other. So when you adjust for those covariates, what we found out was that there are 3 factors that are independently significantly associated with the bone healing complications. And if you look at all those odds ratios, and A1C of more than 7 was about 3 times as likely to have bone healing complications. And surgery time, not many people talk about, every 10 minutes you're associated with the 15% increase in the complication rate in the bone healing. But the biggest factor that was associated with the bone healing was a neuropathy. And if the diabetic patient has neuropathy, you're 4 times as likely to have a bone healing complications when you compare it to the counterpart. So a lot of times when I go to the surgical conferences, they talk about double the amount of fixation, double the time of non-weight bearing, and double the time of the office visits. But when you look at just my data, just doubling all those things don't affect the time for surgery. You actually take more time to put more hardware in there. It won't reduce the A1C level, and it won't reduce the neuropathy. So really not, this statement is not really evidence-based. In fact, I've done a lot of the different types of fixation, try to salvage those neuropathic, devastating ankle fracture in diabetic patients, but no matter what I do, they just fail. Larger fixation, AO technique, or locking plate technique, or I guess standard is like multi-syntesmotic screws. That's a very strong construct, but there's no chance unless you treat the underlying medical condition or neuropathy. That's the most important factor from our study. So this is what we did in the UT San Antonio. When I was back in UT San Antonio, LaFontaine did the study. And we took all the samples from humans, and we just stained it with the immunohistochemistry and looking at the eNOS and all the CGRP that we always talk about in the wound care. And what we found out was that the amount of eNOS and CGRP was significantly decreased in those patients who has a diabetic neuropathy in the Charcot. It's kind of similar to the wound healing findings. And obviously the eNOS decrease in all, not obvious, but the eNOS decrease is actually increase in osteoclastic activity, and CGRP the osteoblastic activity is decreased, and of course the imbalance in those two factors will result in osteolysis or Charcot arthropathy. So those are down-regulated, but there are a lot of other things that are up-regulated in diabetic bones. This is a study we did back in SCON-Y system from the internal grant, and what we did this time was we actually used the animal model. We didn't use a human model for this study. What we did was we purchased all those diabetic fat neuropathic rats, not one of those knockout gene rat with diabetes. But this is actually fat neuropathic rats you could purchase. And what we did was we did the femoral osteotomy, and we fixated with the K-wire, kind of intramedullary unstable construct, and fixated, and we just measured the serum cytokine levels and the growth factor levels. And what we found out from the serum level on this kind of similar diabetic rat model was that those growth factors and the inflammatory cytokine levels were elevated. So these are the ones that actually up-regulated. So a lot of times we talk about diabetic wound healing, we talk about stagnant wound healing and all the stuff, but when you're talking about the bone healing, and these factors are actually elevated, and there's a significant up-regulation of pro-inflammatory cytokines and the growth factors. This is what we look at, and actually this was the human specimen. We actually combined the UT patient population with our population, and we just looked at it, and what we found out, and again, is that the difference in the bone structure. A lot of times you could have a lot of trabeculae and a lot of mass, but a lot of times is what we find in the Charcot patient is that it's actually too dense and like too fragile and disorganized, and you could see a lot of inflammatory cells. So that's kind of like a glass type of appearance that is hard, but it's fragile. It's not flexible to absorb the shock. So what's going on in those diabetic patients, or in a normal patients, when you have a trauma or surgery, what happens is that it goes through the inflammatory phase, which is normal healing process, and it goes on for first 3 days, and it goes on to the osteoclastic activity. That's the physiological osteoclastic activity to try to resolve the fracture site. And that fracture, the catabolic activity causes another inflammation, and just the cycle goes on and on for 3 days or so. But in those patients, in the normal person, what the anti-inflammatory pathway comes in and try to stop this process. and goes on to the bone healing. But when the patient has a neuropathy, which is a number one factor associated with the bone healing complication in diabetic patients, that inflammatory pathway is actually inhibited. So this inflammation cycle goes on and on and on and result in a fracture dislocation and a lot of times a Charcot, or just a bone resorption and non-union. So what can we do for this type of patients? Again, I don't think that the double the fixation will change too much in this patient. This is more like a medical problem, and you have to kind of stop this cycle. There are some places you could work on this. You're actually causing the trauma. You're the trauma surgeon, and you're causing trauma to those patients. And the more trauma you cause, the more inflammation you cause internally. So that's going to result in osteoclastic catabolic activity. So you really have to minimize the surgical trauma for those patients. There are anti-catabolic agents like pharmacological treatments out there to try to stop it without using your own cholinergic anti-inflammatory pathway. So you could work on that. Most of the drugs are really off-label use at this point, but certainly there's a lot of pharmacological agents that could be used. And what happens if you have actual osteoclastic activity in the bone resorption, a lot of catabolic activities? What are you going to do? A lot of times it's going to force your construct is fall apart, and what can you do about that? And a lot of times maybe you could fight it with the continuous compression instead of just using the static compression and holding in place, and bone resorption happens and nothing's going to hold anymore. So you might have to actually keep compressing that kind of construct. Like, good example is external fixation. You keep compressing it. Say you're fusing an ankle joint, you just keep compressing it so that the bone resorption is reduced, and keep applying the stability out there. I personally don't like external fixation. Just pin site management is too much work for me. A lot of the internal fixation nowadays uses continuous compression technologies like a nitinol technology, whether it's the staple fixation or intramedullary nail type of fixation that reduces in length, so that when the bone resorption does happen in those people with a lot of inflammation and neuropathic diabetic patients, it keeps continuously compress the area and achieve the stability until the bone heals, which takes much longer than usual patients. Minimizing trauma is another thing you have to do. Like we talked about, that inflammation causes more catabolic activity, so you have to minimize the initial trauma. So a lot of the ankle fusion in those patients, you could easily do that with the arthroscopic fusion. A lot of the osteotomies, the metatarsal osteotomies, you could either do the open procedure like this on the right, or you could just do the minimally invasive osteotomies with the MEPO type of technique and the percutaneous plate osteosynthesis to try to reduce the inflammatory process, so that you minimize the absorption of the bone between the at the osteotomy sites. Same thing as calcaneal osteotomies. Do you really need to make the big incision, or you could just minimize the osteotomy? One of the biggest things is now popular is the fracture management, the MEPO technique, small incision, enough to slide the plate underneath and try to reduce it percutaneously and transfix it using the lock-in screws and plates. And obviously the wound healing complication is much better. You're not creating the big wound, so that you don't have to have too much headache dealing with the post-operative wound dehiscence. Anti-catabolic agents, now some options are available, the bisphosphonate being the most popular one. Calstone and the rank ligand antagonists are now coming up. Probably most of you use the bisphosphonate at this point. It came from the first famous study Dr. Drew did in the Manchester University, randomized clinical trials, and showed that the significant decrease in pain and inflammation, all the stuff, using the palmidronate, one dose. Since then, so this is a study from Manchester. Because in Europe, a lot of the non-surgeons are treating those problems, the Charcot problems, which is I actually agree with, because I think this is more medical problem than surgical problem. So that's how this study came about, and they did randomized clinical trials, and that was effective. the oral bisphosphonate, alendronate times 6 months, this study had a similar result and no side effects. Again, that bone turnover was less using these drugs versus placebo, and good results. Until this Perkinian guy came from as a Middle East or India, I forgot, but he always does this to scientific community, and they try to come up with a contradictory result, and he did that for this again, and he looking at the zolmedronate and looking at the efficacy of zolmedronate on the Charcot patients, and the result was that if you're using the bisphosphonate, the treatment time was 27 weeks versus control was 20 weeks. They didn't find any significant difference, but it looks like you shouldn't be using the bisphosphonate in this type of situation. But if you look at this study, it's funny that the average treatment for control group is 20 weeks, but if you look at the range, it's 20 to 52 weeks. So obviously there's a math problem there. And if you look at the number of neuropathy patients, not all the patients had a neuropathy, so I don't know how to get the Charcot arthropathy without neuropathy. That's another problem I see in this paper, but he always does this. But there's a study out there that doesn't show the efficacy of bisphosphonate. Rank ligand inhibitors, more and more people use it nowadays. I guess that I personally use it. Anyone use the rank ligand inhibitors? I guess it's better for the kidneys, but my colleagues use it, but I personally don't use it. So rank ligand binds to the macrophage, and that's going to promote osteoclastogenesis that obviously breaks down the bone. So instead of rank ligand to bind to that receptor, this drug actually binds it before it gets into the receptor, so the macrophages doesn't become an osteoclast. Again, this is off-label use, just like a bisphosphonate. Just anecdotally, I hear a lot of success story with this. What about bone stimulators? There's few studies. One is just a case series. The other one is, I don't know, it doesn't say on the paper. But the result, if you look at the result, there's so too good to be true results. I don't see this in my practice, but 50% reduction in time to weight bearing. But the study is out there. I personally don't excessively use this because I think the evidence is lacking, and a lot of it is like osteoclastic activity is over exaggerated in those patients. So increasing osteoblastic activity, I don't know if it's too effective in treating those conditions. But there are studies out there. Again, the quality of studies are not really good. What about osteobiologics? I know a lot of people combine a lot of the biologics and try to make the super biologics and try to pack it in there, and after $100,000 and still see that non-union. I think this is a lot of, it's just, again, there's not much evidence to support in use of Charcot arthropathy, and you'll probably never see that because the Charcot disease is rare, and you have to have probably 1,000 patients in each arm to try to detect the difference between those two groups. But what I'm afraid is that since those Charcot problems, a lot of the cytokines and growth factor are actually overregulated. So it's not that some things are underregulated, and if you try to add more growth factors and the cytokines, I feel like it's actually making more inflammatory process even longer, and end up having the catabolic activity and the bone resorption over time. This is back in the days, and more than 10 years ago, I did the Charcot reconstruction, try to pack everything I could find on the shelf, and look what happened after 20 weeks. So the $100,000 is gone. It's not $100,000. It's probably, I don't know, $5,000. But it's gone. If a lot of people do it, it end up being $100,000. So again, are you introducing more inflammation to those patients? Again, this is not the stagnant non-union. It's actually catabolic activity, bone resorption non-union. So I don't want to add anything that angers that area. So in conclusion, the neuropathy is the biggest factor. I know this is the cardiovascular conference, but the neuropathy is actually in our cohort study that found that the neuropathy is a bigger factor than the vasculopathy and as far as the bone healing complication goes. And how much is the surgical problem? Again, I believe this is more of a, I think European has it. I think that it's more a medical problem than a surgical problem. And a pharmacological treatment may be the future of the treatment for Charcot arthropathy. Again, that the inflammatory catabolic activity that makes the bone healing very difficult in these patients. To combat that, if you still have to do the reconstructive type of surgery, then you really have to minimize the trauma and maybe not more fixation, but maybe different type of fixations. Thank you.
Well done, good report. It's important also because there's too many people putting these frames on at the wrong time. You know it, and I know it. Have you published this data?
Which one?
You just reported on a study you used to with patients and so on, and found neuropathy and found that these patients weren't doing very well. And, have you published the data on fixation and neuropathy and so forth that shows?
Not the fixation. I found the risk factor analysis. That's published.
It hadn't been published. I'll give you my number and send me your stuff.
No.
All right, I'll send it for you.
Yep.
Yeah, it's a big problem. We need more publications like that out there, and we need people out there also who, like me, who speak more about it.
Yeah, I think that a lot of the Charcot was discussed in the surgical conferences more than the medical conference. Yeah, and and they know it too. The results are not as good as They show the best result on the podium and on the screen, but that's not what's going on behind the scenes. So.
Thank you very much. Now we're going to have Dr. Ulcer come up, and he's going to kind of complement the last lecture. He's going to go over the radiographic findings with diabetic bone healing and Charcot.
So this is largely, once again, an imaging talk on fracture healing, focusing with emphasis over on the diabetic foot, especially Charcot neuroarthropathy, neuroosteoarthropathy. And so let's get started. This is a typical look of a diabetic foot with underlying neuropathy. When I teach the class, half the stuff that was in the old literature is there. They've got deformities of the metatarsal heads, fibroid-like deformities. You've got a spindle shape with the fourth proximal failing, so you've got usually deformities of great toe is one of the things we see with neuropathy, and obviously we have Charcot changes through the midfoot. Is it our imagination? Is this just trauma, or is there an inherent problem with the diabetic bone that predisposes them to this? I think there's enough literature out there on this topic. We're going to briefly review a little bit of that, but Dr. Shabui has done a great job on that, so there's very little for me to add. I'll look at a couple of studies on that and then get into the healing part. Hopefully I can show you what's coming up in the new stuff that's coming out. Not so new, but maybe new to some of you as to how to assess whether, in fact, things are healing. So is this bone fracture or fusion healing? We're all familiar with some of these classifications of non-unions. And, if this was a little longer talk, we could talk about data that suggests that some of the ideas behind the vascularized non-unions versus the non-reactive type. These are vascular types, and we all learn the horse's hoof and blah, 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 elephant's things. And these are some of the torsion wedge and some of these things that are non-reactive. These are presumably non-vascular. You have to remember that in the Charcot foot, basically circulation is generally not a problem. These people usually have some type of hypervascular problem. So in principle, circulation is not the primary factor in healing in Charcot. We have these images where we clearly have what looks like perhaps a hypertrophic non-union. Is it healed or is it not? And the radiographs are not all that conclusive. And yet we do see non-unions in the foot. They can happen with metatarsals. You see here's an atrophic non-union on the right, logotrophic on the left. These things happen in diabetic feet. All these are diabetic feet. So risk factors for non-union, we go through this list, and I don't need to belabor the fact that, do you have the degree of fracture, comminution, presence of factor Graft. I want to go to the last bullet on here. Patient biologic factors, we're talking about diabetic patients, and what are some of these potential factors? So I went to look at a little bit of the literature on here. That's because I absolutely have no social life lately, and I have nothing else to do. So I decided to read the impact of type 2 diabetes on bone fracture healing. This article by Mri, it was published in 2018. And there's no question that there's increasing evidence that suggests that type 2 diabetes mellitus adversely affects the skeletal system. Some of these detrimental effects are bone quality deterioration, loss of bone strength. Increased fracture risk has been demonstrated interference with bone formation and impaired fracture healing. The question is, what's going on to do this? And it's probably multifactorial, but as you already heard, neuropathy is a major factor in this. One of the things that I'm going to come back to is that most cases of Charcot arthropathy, since it's an arthropathy, we're dealing with subchondral bone, which is largely cancellous bone. And so all the rules for cortical bone healing and fracture determination on imaging have to be tempered with the fact that most of the time we're dealing with assessing cancellous bone, and that's tougher, as we'll see. I thought this was an interesting article that looked at callus adiposity, the modulation of osteoblasts into fat cells in type 2 diabetes. This was done with, it's a murine model, but it's been already cited a number of times, a study by Brown et al. In 2014 that looked at delayed fracture healing. They used something called micro and nano CT scanning, which we're going to kind of talk a little bit about as we get into this lecture. And they were basically doing, this is a high-fat diet, HFD-fed mice only. And they saw these trends with, compared to their normal diet mice, that there was a trend at day 21 toward decreased callus vascular volume and decrease in actual callus bone volume. And then they saw that there were decreases in woven bone area by day 28. So they were able to note these changes using very fine techniques, high-resolution CT scanners, in order to see these changes. Nano-CT is not, I don't believe, something that's really commercially available nowadays, but high-resolution peripheral micro-CT, which we'll talk about, is. One of their conclusions in green was that micro and nano-CT is very accurate in regulating this. One of the things they noted was increased callus adiposity, which is rather interesting. And of course, linking into the previous lecture, the role of neuropathy on fracture healing is, there's a fairly recent article, 2010, that talks about it. And, neuropathy is an absolute prerequisite for developing Charcot osteoarthropathy, as we heard. It's hard to imagine that someone has Charcot changes without neuropathy. In this particular article, they thought there was a possible downregulation of the inhibitory nerve pathways that can result in an exaggerated response to trauma, and then you have minor trauma starts this inflammatory cascade, and then you get rankle going and all that type of stuff. So rather interesting. But anyway, the bottom line is there clearly are a number of factors out there that seem to predispose these patients towards fracture. So on to the major topic, imaging. How is this affected? And I've already said cancellous bone is really the key part that I'm going to move towards fairly quickly in my lecture. We'll talk a little bit about general principles as I move to cancellous bone healing and the problems with determining when you have trabecular and microtrabecular restitution of bony integrity. Most of the time, cancellous bony fractures, periarticular fractures, don't have dramatic callus, all right? I think you probably all know this. In the midshaft of bone, fine. But when we're at the ends of bones, we don't have callus. So now we have to make some kind of an assessment based upon the imaging system as to whether there's been restitution of integrity, restoration of trabecular patterns. That can be tough. Some very good references if you want to read on the topic. This one by Roth I found in 2017 is very good out of Current Radiology Review. And Morshed has some very good articles also out there. First thing we'll start out by saying there's no standardized methods for assessing fracture union. And so there's quite a bit of disagreement, as you can kind of see here. We'll start with what we know, plain radiography. And once again, we're going to kind of quickly move towards the diabetic foot here in a bit. But quickly in a bit, isn't kind of oxymoron, or something like that. But qualitative assessment, it's a qualitative assessment of, once again, callus formation, callus aging, so to speak. We can follow callus aging. Cortical bridging is one of the things we look for, loss of fracture line, which we're all familiar with in trabecular consolidation. So what are its advantages? It's ubiquitously available, widely available, low cost, low radiation dosage. The single biggest disadvantage besides geometric distortion overlap is low resolution. Once again, if you're going to try to assess trabecular patterns being restored around the Charcot midfoot based upon this after you've put a plate on, it's going to be a little tough. You know, once again, the resolution of your imaging system matters, just like the resolution on your TV set. And now we're going digital. So this brings up the other issue that I don't have time to talk about, but now you have spatial resolution versus contrast resolution. And, you know, spatial resolution tends to, depending on the digital system, lag behind that of film-based, usually. Now, flat panel detectors can come up to high resolution, high contrast film. Contrast resolution is the other issue. So it's an iffy proposition, and you have a lot of what we call post-processing algorithms that try to make it look sharper. When you magnify to look at those trabecular patterns, you start seeing pixels. Poor correlation with mechanical strength. I don't think I have to review primary and secondary healing. I think we all know that if you have direct contact, you get those osteoclastic cutting cones that get juiced up and crossing the gap, and then at the back end of it, you got your osteoblast forming bone, et cetera, et cetera. So, so when you look at radiographic examples of these are all diabetic feet. Can you tell, actually, based upon the radiographs, here, you know, at what point in time is this thing healed? We can sit there and say we're losing conspicuity of the fracture line, but there have been many cases. I've got a case, hopefully we'll get to by Dr. Shook, that demonstrates this. This is secondary healing, where here we see the callus. And once again, we can confidently say at 9 months it's healed, but somewhere between 3 months, I don't know, at 3 months, are you sure, you know? We think it's healing, it's well on its way. We're losing some sharp definition of the fracture margin. We go through all this. The callus is now organized, right? I would say probably a lot of times we'll sit there and say, well, clinically it's getting better, so I feel comfortable. Same thing with the foot. The one on the left, healed. The one on the right was thought to be healed and is now displaced, all right, in this diabetic patient. This thing is displaced and it's overlapped, it's hot off the bone, it's falling off the bone, thought to be healed at one point in time. So, out of this article by Cunningham, one of the things that we can sit there and note that radiographs have not been shown to be reliable or accurate when defining union or determining the stage of healing. It's just something we have to get used to. Do you know for sure, is this thing healed or not? So we use radiographs all the time. Most of the stuff I saw in the residence competition and whatnot were radiographic images, and I get that, all right? But, you know, I think a number of us have also seen horror stories with this type of stuff. This fracture was not healed until 12 months. At 8 months, what would you have said? I mean, it's still probably open, but, you know, once again, how certain are you? Is this healed or not healed? Let me just kind of. So once again, the key thing, that message I'm going to come across with is that if you're looking at periarticular areas and at Charcot neuroosteoarthropathy, it's a joint problem first and foremost. We're going to be dealing with periarticular areas. Bone callus formation is either absent or considerably less obvious. So what are the other options moving away from radiography? Well, there's absorptiometry and photodensitometry. You know, it sounds like a big long word, but you've all heard of Dexa scanning, dual emission X-ray absorptiometry. And what about Dexa scanning, where we can get what's known as an aerial bone mineral density? It's a two-dimensional measurement, not a volumetric density measurement of bone density. Well, I mean, it certainly is readily available, low cost. The bottom line is that it has not been shown to have been reliable in determining whether or not these things are healing, all right? So, you know, there is some data to support it, but once again, it's not routinely used. So let me move on to computed tomography, since my talk is quickly coming to an end. I have a feeling time-wise, but it seems like I just started. It is the procedure of choice, and once again, you know, I'm always looking for CT scans on some of these with plates and screws and stuff like that. But the understanding is we can get beam hardening artifacts, but CT scans generally are one of the ways where you get rid of geometric overlap, increase the resolution, and we can clearly see what's going on, usually, all right? So it's been shown in a number of reports to have a sensitivity up to 100%. So here's our potential non-union from before, and now there's no question about it on a CT scan. So once again, all the doubt is when you go through sectional imaging, and we can literally take a close look with much higher resolution. You see the sclerosis, and obviously this is a non-union. It has some disadvantages, okay? One of them is, in fact, that it's said to have in some studies for non-union low specificity. And obviously radiation dosage, all right? CT scans in general have higher radiation dosage. Enter something called QCT, quantitative CT scanning, which has been used for many, many years now as the go-to agent along with Dexa scanning to assess bone mineral density. So quantitative CT scanning is not new, all right? It measures bone volume and density and is the procedure choice to look at bone mineral density in cancellous bone, all right? Not Dexa scanning, all right? So, and it gives you volumetric, not an aerial density. So that's great, all right? It looks like maybe we ought to go QCT, but it is high radiation dose, and it's still not high resolution, all right, by comparison to some of the newer tests out here. So there's something called three-dimensional QCT, and when you get to three-dimensional studies with something called microfinite analysis, where you can get a measure of what's called Young's modulus and bone stiffness and strength, which is something that's new. Now here's a case study that Dr. Shook has provided. I've cut out some of the images, but I'm gonna let Dr. Shook quickly comment, because this was his case study, as to what the natural course of history was with this. But as you can kind of see, a 56-year-old female that had turned her ankle and admitted to the ER within 6 hours. The ankle films are read as negative, and that's, once again, let me go back here for a second. I don't know that, well, there may be a transsclerotic band there, but go ahead, yeah.
You can see it. The lady was in the ER, and she had ankle pain, lateral ankle pain. You can see the transverse fracture line of the fibula just above the syndesmosis level. But the ER didn't get it, but they put her in a walking boot, which is more than reasonable treatment for that. Go ahead and go to the next.
So this is 2 weeks after the ankle
2
sprain.
weeks later, her boyfriend, who is definitely king of the knuckleheads, was pushing her to the doctor's office to get a follow-up visit, hit a thing in the sidewalk and threw her out of her wheelchair. She landed on her ankle, and now she has an extra-articular pelon fracture. You can see on the lateral, the distal anterior tibia.
Yeah.
You can see the line on the
And you could probably pick out the small subperiosteal hematoma or something there also, so.
So I admitted her because she had diabetes, she had significant pulmonary disease, she was schizophrenic, cardiac disease, hypertension, she had the whole deal. And so I admitted her strictly as a disposition issue, put her in a cast, got her walker trained, and sent her home to follow up in a week. So you see the date on that is 5/7/16. Go to the next one. So this is now a month after she's in the cast. She didn't come back a week after the hospitalization. She's obviously been walking on the cast. So now this is an operative extra-articular pelon problem. And we actually did her surgery with the popliteal block. She was awake and talking the whole time. You can go to the next one.
Yeah, I cut out a bunch of those because I figured it was going to run out of time. But, so I'm going to show a postoperative course at 14 weeks. How about that?
So I basically did this percutaneously. The plate was put on percutaneously, the screws were put in percutaneously, and I put a frame on her. She was in like a skilled nursing unit for about 6 to 8 weeks, and unfortunately got discharged. And I really couldn't tell what was going on with the frame. She had a ring fixer, a standard 4-ring frame. And the last time she came in to see me, I noticed that the foot plate wasn't where I had left it. And so I looked at all the nuts, and her husband was actually going to Lowe's and getting nuts and taking them off and putting them back on because she felt that it was painful when they were tight. So we're now at 14 weeks. I take her out of the frame, put her in a cast, and that's what you see.
And I was just say, how long was it before you think union was certain in this patient?
I did not think it was certain here, so you can see the next.
Well, I think I kind of took the rest of these out just because I figured I was going to run out of time. So.
Well, basically, I got a CT scan of a conventional
So enter the main part that I want to kick to over is so-called high-resolution peripheral QCT. I wish there was a fast way to say that, but there may not be HRP QCT or something like that. This is fairly early study looking at its ability, looking at microarchitectural assessment in type 2 diabetic patients by Burgart. These patients on this particular study had significantly increased cortical porosity along with what we call a 10% increase in volumetric trabecular bone mineral density. One of the fascinating things of this study, which for some reason has not been widely quoted, is they noted that one of the reasons they think that there's a fracture increase in these type 2 patients is that the trabecular pattern that that is being laid down is not necessarily in an efficient way. It's in an inefficient pattern, and so it's unable to handle loads. And that's one of the things that was demonstrated in this particular study. But it's one of the early ones with micro-CT. One of the ones that everybody looks on is Just de Jong et al. Several studies came out by this group et al. And they're looking at bone mineral density in distal radius fractures, which is cancellous bone. And as you can see here, they had 18 patients in this particular case with stable distal radius fractures. They were all scanned at 1 and 2 weeks, 3 and 4, 6 and 8 and 12 weeks post-fracture. And there was a control on the opposite side. And then he used this high-resolution peripheral QCT along with what we call microfine element analysis. That's my abbreviation for that in the last thing. And microfine element analysis is to tell whether or not torsioning and bending and compression is actually being assessed also, things that we just normally would not be able to think is reasonable. So here's a typical interarticular fracture. And if we look over here, this is the type of readout you get from high-resolution peripheral CT. The color coding shows high mineralized bone in blue. The green is low mineralized, and soft tissue, vascular tissue, early forming soft callus, things like that, is somewhere between red and green. And then Young's modulus can be calculated from this type of stuff, basically giving us an idea of bone strength, for example. So visit 1, look at how long it takes before in cancellous bone you get a feel for whether these things are healing. Remember, this is visit 1, which is somewhere around first week. Somewhere around 3 weeks or so, 3 to 4 weeks, or 2 to 3 weeks, excuse me, is visit 2. 6 to 8 weeks is visit 3, and 12 weeks by visit 12, we're able to see that for the main part, looking here, there's still a little bit of areas which are not consolidated, but for the main part, this main fracture line we see this restitution of trabecular integrity. You cannot see this on radiographs. You really cannot see it in terms of resolution with straightforward CT scans, all right? This is much higher resolution instrument that's able to get down to 80 to something, whatever microns. You're gonna get down to a level where you can assess this. And this technology is here now. Here's this 3-dimensional reconstruction of the same thing, showing the distal radius fracture, visit 1, visit 2, visit 3, and you see at visit 4, clearly there's been some consolidation. Here's an extra-articular radius fracture, and here was the 3-dimensional look of it, and the arrows kind of point to the fractures distally, and you kind of see a fracture line longitudinally here also, but this is the up-close look at this, and once again, over time, by visit 4, we start to see filling in of trabecular patterns. 2 dimensions, the fracture line's pretty obvious here and here. Once again, visit 2, kind of see maybe there's a separate piece here, fracture lines here. And now we're starting to see restitution of integrity by visit 4. But, I mean, this is definite. I mean, this is not something that's being guessed upon. This is another study that was done by Just de Jong et al., but basically reaffirming the results of the 2014 study. This Goossens study talks about this and gives us an idea on some of the other uses, but suggests that this technology is here, all right? This is high-resolution peripheral QCT. When we compare this in terms of its nominal resolution, 82 micrometers, compared to standard conventional CT scans, all right, and look at the effective dose. This stuff is low radiation, low radiation. So QCT of the spine, once again, this is a significant increase in its nominal resolution in order to assess trabecular patterns. Here's an example of color coding. Here's an example of color coding where it doesn't want to stay. Where, once again, here's our fractures at the arrows, all right, and red is resorptive changes. Green, sorry about that. Green, I'll just leave the mouse alone. Green is our newly formed bone, and blue is the original bone. So you see that by week 12, for the main part, trabecular structure has been restored. The remaining couple of minutes, what I'll do is talk briefly about something called digital X-ray tomosynthesis. Tomography has made its way back in terms of something called digital X-ray tomosynthesis. Its great use is probably when you get plates and screws in a way, and CT scans are giving you beam hardening artifacts. This is something that you should consider. This is a 2015 paper by Chu et al. Basically, it has the same principle, like the Grossman principle, all that stuff that we learned for tomography. Now there's a digital aspect to this. I just want to show you, it's not necessarily an improvement over CT in most instances, but sometimes it can. We're seeing it come out, more and more studies come out in the papers lately, 2016 study. Plain film radiographs or plain radiographic images on the left, is this scaphoid fracture healing or not? Reformatted CT is unclear, but you would probably surmise that it's not united. The digital tomosynthesis in this particular example, in the presence of hardware, is the best of the three images on the lower right. And then sometimes, once again, like this, the digital tomosynthesis in this particular instance underperforms compared to CT scan on the lower right. So it's not going to replace it, but it's an option when you have a lot of hardware. It's a fairly simple go-to option. I'm going to finish by one quick statement, is that no one's talked about dynamic MRI in Charcot, but since Dr. Shabui's talked about the overall gestalt, and I don't want to say gestalt, but the overall idea behind fracture healing and osteolysis and whatnot going on in Charcot. The hot thing out there now, especially in Europe, I just got back speaking there, is dynamic MRI scanning to just generally assess whether or not the Charcot foot is healing. This is the original study that kind of demonstrates that, in fact, this modality should be strongly considered. And this is where you're basically adding contrast medium to assess. They're not breaking up the concrete now, are they? Okay. This usually happens during my lectures at school, so. But anyway, so they looked at 40 diabetics prospectively with acute Charcot neuropathy. And all patients underwent limb immobilization, as you see here. They were followed every 3 months to a maximum of 1 year. Clinical exams and MRI were performed. And what they did is they did standard MRI, all right, where they had two blinded radiologists look at the MRI. They did standard uptake ratios and said, all right, let me find a spot where there's no marrow edema on the T2-weighted image, and let me find a spot where there's max marrow edema in the middle of the Charcot joint problem. And they did this, and they had to stay away, for the normal reference points, they had to stay away from subarticular areas. So they said, let's do that, and let's do what's called a signal uptake ratio, and compare it to contrast-enhanced studies doing the same type of thing. So the bottom line here, and I'm going to get yanked off the stage here, is the bottom line was that they looked at these contrast uptake ratio and DMRI, and what they found was that the most reliable thing was this contrast uptake ratio. All right, it was reliable. All right, and it seemed to correlate with healing very well. All right. It wasn't related to any clinical variables. There was no relationship to the change in temperature, but what it was good is at predicting healing in the Charcot foot. So this is the conclusion. It represents a reproducible parameter that is reliable for monitoring treatment outcome in acute diabetic Charcot foot. An example of some images, but that's beyond what we need to do. Thank you. Sorry for running over.
Next lecture is going to be Jeff Manweg, and I catch my airplane. Dr. Osher is going to take you guys to a couple more lectures. And I just wanted to thank everybody for coming, especially the people that lectured. It's a long trip for a day program, and I truly appreciate your efforts. And we're going to try to do it next year and hopefully get things done a little bit quicker, market it, get more people involved. So thank you very much for your participation this year.
All right, so in light of the discussion, I think with Dr. Kravitz and Dr. Shibuya, I just wanted to emphasize here, I get to have the fun part of going up here and talking about surgery and hardware in the setting of Charcot, but the reality is that Charcot is not always a surgical problem, and I think it's easy to get up here and everybody's excited, particularly when you're training people, they want to learn how to do surgery. But Charcot is not a license to do surgery. I think we have a big problem in this country, particularly in failure to recognize things in a timely fashion, and ultimately it progresses to a point where patients may need surgery. I think the goal of Charcot surgery is ulcer prevention. I don't personally look at the goal of Charcot surgery as a stable osseous fusion. My goal is to give someone a functional plantar-grade limb that's not going to ulcerate and put them in the hospital over and over again. So I will be perfectly honest with you. I have definitely my share of failures and non-unions, and I'm happy to show them to people. Actually, I'd much rather see a catastrophe up here than something that was a success, because just like everyone else, it's much more fun to watch a NASCAR race where there's a car wreck than one that sails right through to the end with nothing. But I think it's important to keep clear, particularly Charcot of the midfoot. There's plenty of literature to say, if you like, per se, look at Pinzer's article, 60% of these don't need to be treated surgically. They can be treated non-surgically with a stable limb. I think the goals that you need are to sort of look at the guidance that you have, look at Bevan's article in negative 27 degrees being predictive of an ulceration, or look at Wukic's article, negative cuboid height being a predictor of ulceration. Because you're going to have to defend yourself if you choose to do surgery on these patients. And so sometimes I'll do things acutely, which is outside the norm. Sometimes I won't do things at all. But I think the goal is ulcer prevention, because that's the thing that in the literature has been directly linked to poor quality of life and mortality. So I don't think we should lose track of that, certainly. And as a great point brought up, this is just sort of a brief sort of technique that we have, I think, championed a little bit in Pittsburgh and then reversed ourselves, ironically, a little bit on over the last couple of years. But something that we would call a pan-foot arthrodesis, meaning traditional fixation of a Charcot midfoot when it's indicated generally involve what we're talking about, axial beaming or plantar plating, but addressing the midfoot and perhaps excluding the ankle. And what we mean by pan-foot is always including the talus and the ankle in our construct, and even in sort of moving towards the future, what we've done more recently is excluding the foot and including only the ankle, basically with the idea that the talus is actually the real problem here. The fact that it is a fairly unconstrained bone, there's a lot of shear and a lot of movement, and if we can control the talus, then perhaps we can make a plantar grade foot, limit some of the surgery that we're doing from a hardware perspective in certain cases, and have a functional limb that's not going to ulcerate. So, I mean, this is a perfect example. This person may even actually have a reasonable angle as far as their lateral talar first med angle, but they certainly have a negative cuboid height here. And you can look at the articles from the West Penn guys. Is plantar cuboid exostectomy appropriate here? But it's the lateral column, so maybe less successful. But what we're talking about is that we obviously, as Dr. Shibuya and Dr. Osher have discussed, we have poor bone, we have multiple centers of rotational angulation. In this case, we have some vertical plantar flexion of the talus relative to the tibia. It doesn't look crazy relative to the calcaneus, but there's definitely plantar flexion here. And we have talonavicular involvement, and as anybody who's done surgery on the talonavicular joint knows, there's not a lot of bone here. It's a relatively poor bone as it is. The talus is a relatively soft bone. So if you're going to do this, how can you do it successfully? Contraindications of this technique, certainly acute infection, previous pathology of the heel, open ulceration around the heel is a relative contraindication. If I have a clean ulcer of the heel and I have completely negative negative inflammatory markers, and it's something where a patient is going to be deconditioned, as Dr. Shibuya is saying, I might go forward with surgery earlier to say prolonged immobilization is not in this patient's best interest. We have to do something earlier rather than later. So, I mean, I love showing failures, as I said, and these people are both mine. I'll proudly admit it. Things that have happened to me: intraoperative tibia fracture, postoperative tibia fracture, failure to pass the nail through sclerotic bone. Nail fracture or hardware failure is the norm, not the exception. Calcaneal cutout of the nail, particularly pulmonary embolus. This is not benign. I once looked back at my patients that I saw as hospital consults, and what I found after 90 days, that my 90-day mortality for patients that I met for a single inpatient hospital day, all comers, whether that was nail consults, wounds, infections, Charcot, ankle fractures, was 13%. So if I met you in the hospital on any given day in Monroeville, Pennsylvania, or downtown Pittsburgh, there was a 13% chance that you were not going to survive for the next 90 days. These are sick patients. And so you have to weigh the decision to go to surgery very carefully. Are you going to kill someone potentially? But below the knee amputation, you name it, death. So as we see here, this is a gentleman who came in with an ankle Charcot on the left. We've nailed him, and he's got the nail now protruding from the bottom of his foot. We have somebody here who we tried to get ahead of. They did not ulcerate, but they were certainly starting to dislocate at their talonavicular joint. We get everything reduced. We're high-fiving, and unfortunately, she's a big lady. She's probably 420 pounds. So she gets up and walks on this thing about 3.5, 4 months in and snaps everything in her foot. So figuring out what the best thing to do is for these patients and recognizing your host is important. So this is what we're really talking about here today is a evolution of the superconstruct. I think most people who do Charcot surgery are familiar with this idea from Samarco. You know, we're talking about truncation of the foot and ankle, the maximum amount of hardware that the soft tissue will allow, spanning outside the zone of deformity. And this is where this technique in intramedullary nailing, as we'll also talk about in my other lecture, really becomes advantageous, because your intramedullary nail, the working length of your nail is the length of your fixation. This is a device that's managing this process by surface area. And so sort of the longer you go, the more fixation you have, and it's intramedullary, so the skin tolerates it quite well. So we're getting happy faces here. We're meeting a lot of our criteria. So disadvantages of doing something like this is a lengthy operation in a compromised host. I think, as we've talked about, deconditioning is problematic. It's expensive. I think we always are erring on the side of more biologics and more hardware. And I think I would agree 100% that packing a bunch of allograft bone, in my experience, I haven't been impressed. And I've used everything. I've used Vivigen. I've used BMP2. I've used things from $300 to $3,000 as far as bone graft, and I haven't been overly impressed with one versus the other. Maybe with the exception of autograft, but there's a limited supply of that inside human beings. So, can we make things too stiff? Certainly, as I said, hardware failure rate is high. Is that okay? I think hardware failure is fine, as long as it's not infected hardware failure. My goal is ulcer prevention. You can have as many broken screws in you as you want, as long as you don't have a hole in the bottom of your foot. I'll give you a boot. And double upright bracing for me is the norm after this sort of stuff, because of the edema that patients have, whether surgery or no surgery. I think it's a fantastic device, and Forrest Gump was a great movie, and so you can just tell them, listen, I'll give you this Forrest Gump brace. He ran across America. It's wonderful. But another great example of this sort of multiple choro, we see a plantar flex talus, we see plantar calcaneocuboid sort of dislocation, we see complete lack of apposition here on our AP talofirst metatarsal joint. So this is someone that we think is going to ulcerate, and so we move forward with fixation here. Again, with the mentality that we want to control the talus. Another patient here, this is someone who's had active Charcot, trying to treat this non-surgically, but again, the host is always a problem. In this case, she can't get out of her own way. She refuses to be non-weight bearing for any period of time. So what do? I put her in a ring fixator with a circular ring around the forefoot. So unless she's capable of balancing herself on a circle all day long, she's going to be non-weight bearing for me. And things calm right down immediately, and then we go through and maybe fixate things definitively. But As an example of failure, this is one of my partner's cases, and looking at, this is something that's starting to become unstable medially. And we always are concerned about plantar ulceration, but certainly medial ulceration is a problem as well. So when the medial cuneiform starts to pop through the side of the foot, we have a decision to make about whether or not we want to proceed with surgery, bigger shoe, a lifetime in a crow walker. And so we decide we'll pull the trigger on this and do something different and do this sort of pan-tailor technique, including the ankle, and basically just removing all motion, all shear, all force that is going to try and cause an ulceration in the future. There's definitely a role for external fixation. I think that's basically what we're doing. If you think about external fixation, one of our goals with it is stability of soft tissue. It's not just for bone. We do this for open fractures all the time as well, and we put an external fixator on people because instability begets inflammation, and inflammation is not a great thing for wound care. And so if I can take this model of external fixation and put it internally, then, as Dr. Shibuya was saying, I don't love the idea of pins sticking through people's skin, so I'm going to shish kebab somebody with metal internally instead, and try and stabilize their soft tissue, heal wounds, prevent wounds. This is a great example of a young lady who I saw who was 34 years old, and she comes walking in on this dislocated ankle and subtalar joint and midfoot, and it's a terrible story, but she's 425 pounds. We do a sort of staged procedure. She has a wound, so we put her in a ring external fixator. We treat her with antibiotics. We suppress infection, and we get her sort of lined up, and then we get her, after infection is cleared, to what we would call a pan-foot arthrodesis. We're bridging both the medial and lateral columns. We're fusing the ankle. And about 4 weeks after this surgery, and we're high-fiving ourselves, she's dead at 35. And so, you immediately think to yourself, did I cause a pulmonary embolism? Did deconditioning cause this? The autopsy comes back with no PE, and ultimately what it turned out with her was a drug overdose. But these patients are sick. There's no doubt about it. And you'll suffer some heartache if you start taking care of these people and doing these things. As I said, hardware failure, nothing lasts forever. As this version of Axl Rose would say, I have broken everything. The goal is not intact hardware, stable hardware. The goal is ulcer prevention. And that's where quality of life lies. Ulcer and infection prevention, as it were. Sometimes you're the cause of infection where there was none, and then you have to answer for that. So I think the thing is, we don't really understand what the best course is with these patients, and I think both sides allude to that. The advocates of medical management, the advocates of surgical management, we really don't know who should have surgery and who should not. But from a technique standpoint, one tip I would give you, that if you're going to try and do something like this, prepare everything first. It is god-awful miserable to try and prepare a midfoot that's already fused in dorsiflexion because it's so subluxed, and so you'll be sitting there trying to squeeze your head between the foot and the ankle. And so I generally recommend that everything gets prepared first rather than sort of the traditional dogma of start at the back and move forward. I really think that you have to do this sort of all at once. So it's back and forth through incisions, it's provisionally closing things with staples halfway through to try and prevent infection. And if you're lucky, it's a surgery that's going to take you 4 to 4.5 hours. So not fun. You sit there and close 10 incisions for an hour. And this is sort of our series of maybe 50 people that we've done this way. There have been as many failures as successes, but again, a patient of my partner's, this is somebody who's failed local rotational skin flap, he's failed crow walker, he's certainly got the definition of a rocker bottom foot, and so we do a midfoot osteotomy and fuse his ankle, and he has nice limb salvage. This is a young lady, again, 35 years old. We see very unhealthy hosts in Pittsburgh, but this is how she this is a gentleman who's 56, and he has bilateral Charcot, and his subtalar joint's turning into a ski slope. His talus is basically running away. He's dislocated his talonavicular joint. We're worried that he's going to ulcerate over his talar head. So we put him together with this sort of, again, pan-foot model, getting the column stabilized, also fusing the ankle. He decides to go hunting from his truck 4 weeks after surgery. Whether he had the stroke first or aspirated first, I can't tell you, but he was found unresponsive by his truck out hunting in the woods. He had his rolling knee scooter there with him, so I can assume that he was non-weight bearing. he got life flighted to our trauma center, where he was treated empirically for all manner of sepsis, whether aspiration, pneumonia, or otherwise. When he woke up, he was angry at us for saving his life because he said he had a DNR and a DNI. He has no functional deficits now, but he would tell you that maybe he wasn't happy that he went through things with this, but he has both of his legs. This is the young lady I was talking about, and so what we talk about sort of the sans foot arthrodesis, or excluding the foot completely and just including the ankle, and she's got peripheral neuropathy from rheumatoid arthritis, not even diabetic neuropathy, and this is sort of how I met her, only to get worse. She has an open wound, osteomyelitis of the talus, and so we treat her with a spanning ring external fixation and talectomy with an antibiotic spacer. You can see my little donut there. I tend to make it hollow in the center so I can do a Childress pin up through it. And then once she's clear of infection, we just dock her with a tibiocalcaneal arthrodesis and let the foot float. And it seems to be that they accommodate well with that type of motion. And so this may be more of our future rather than doing everything, is this idea of maybe less is more, but doing less in a different way. Doing it instead of directly treating where we see midfoot Charcot, treating the ankle and just simply slowing people down, slowing their talus down. But as I said before, I do treat all of these patients sort of conservatively through their post-op, and all of them get a double upright AFO for life, try and accommodate for these deformities. So I guess my closing thoughts is a demanding surgical procedure. If I can catch people early enough, surgery is not the norm. I think there's plenty of research to suggest that if you can catch people in the first 10 to 12 weeks, you can avoid surgery in most cases. And so I think that's paramount, getting out there and educating your other specialists in the area so that you can get these referrals or get these diagnoses as quickly as possible. But if it's necessary, I think controlling the talus is an important thing to do as far as treatment of Charcot and ulcer prevention.
All right, not many people left, but thanks for sticking around, for those of you sticking around. I love talking about amputation and limb salvage conference. I'm going to talk about amputation. Is amputation all that bad for Charcot foot? Obviously, you look at his slides, and it's a lot of work and a lot of complications associated with those reconstructive surgeries. And is amputation is really any worse than what you go through with reconstructive surgeries? That's my topic. So generally, amputation is believed to be bad because you lose function. Cardiopulmonary reserve is lost because of the loss in volume, and quality of life goes down, and it's not cost effective. And like he was talking about, you die after amputation. How many times I was asked when I was a student, what's the rate of death after below the knee amputation, or what's the contralateral amputation after BK? But is the death really a causative factor for death, or is this just the association for death? So what we did, we look at those people who had an ulcer, and those people who had a BKA, and those people who had an AKN, and look at the 5-year mortality. The study on Charcot comes from someone else, but the other 3 are coming from our group. And what we found out was, indeed, if we do the proximal amputation, you die faster. So if you look at this 5-year mortality, it's much higher if you have the AK versus BK versus ulcer versus Charcot. But something else we found that was interesting. The average age in these cohorts are significantly different between those two groups, those 4 groups. So if you had an AK and our cohort was 69 years old, as opposed to those people who had an ulcer was 67 and BK was 66, so 3 or 4 years behind AK. So of course the 5-year mortality is going to be much worse than the AK. They're 3-4 years closer to death to begin with than the BK or ulcer patients. And Charcot cohort from these studies, at the average age was 61, so they tend to live longer just naturally because of the age. This is the VA data. It's kind of hard to see. So if you work at the VA, you have access to these data. And I pulled these data in 2015. And if I go back to those people seen in 2010 and looking at the mortality, so it's considered five-year mortality because I'm going back 5 years. The 5-year mortality was much worse. So if you had an AKA, again, more proximal amputation, looks like it's killing people, but again, if you look at the average age in those two cohorts, that they're about 4 years ahead of a BKA, so of course they're going to die earlier. So a lot of times when I go to like a wound care product dinner lecture with the steaks and wine and stuff like that, they always show this editorial from Dr. Armstrong's paper. It's not even a study, it's an editorial. And they always show this neuropathic ulcer being 5-year mortality is significantly high, it's higher than breast cancer and the prostate cancer. Therefore, you have to heal the wound as soon as possible to save his life. That's their claim. But obviously, the one thing you could tell is that the cancer killed people, breast cancer killed people, but the ulcer doesn't kill people. It's just the associated factor rather than the causative factor for death. And what's more interesting is right next to it is amputation. So if you have an amputation, that the 5-year mortality is about the same as those people with ulceration. So, should I heal the ulcer or just amputate because the death rate is about the same? This is a renal data, that the U.S. renal data system, and if you look at those people from 65 to 69, I picked a range because when I look at those the 5-year mortality in the BK, AK, and the ulcer patients, it's about 65 to 69. And when I look at it, those people who are dependent on the dialysis, that their the average life expectancy is about 3.2 years. And this data on the left, the 2-year survival, those people had a vascular procedure, the 2-year survival, not the 5-year survival, is about 47%. And this is the data we collected from Central Texas and San Antonio when I was a fellow, actually. If you draw the line at the 2-year mark, so the x-axis is days, and the y-axis is the survival. If you draw the line at the 2-year mark from the dialysis, we actually went to a whole bunch of dialysis centers and followed those patients for years. And when you draw the line at 2-year time, that the survival is about 65% or so. So it's not really amputation. So you can see that middle line is the below-the-knee amputation. If you look at the below-the-knee amputation, the survival is about 65%. So this amputation doesn't really hasten someone's life. It doesn't really causes the life to be shorter. Rather than it just the associated factor, it's a proxy for the sickness or the higher age or having more comorbidities. So this is a diagram I always show. It's kind of fun. If you have diabetes, once you have diabetes, and every day you're getting closer and closer to death. And on the way, you're picking up neuropathy and a vasculopathy, and when you get closer and closer, you're going to develop the cardiovascular issues, and the renal disease is one of the latest part of the spectrum of natural history of diabetes. And the below the knee and above the knee amputation sits somewhere right here. If you look at my mortality data, it's like about 5-year mortality is about 50% of those patients. And of course, the ulcer is right behind it. So when I get the surgical consultation in a diabetic Charcot patient and things like that, first what I do is I want to see where your Charcot patient fits in this spectrum of a natural history of diabetes disease. If it's right behind a BKA or even death, then is it worth going through major reconstructive surgery, going through a lot of the conditioning to reconstruct those patients? A lot of times I use the Christmas tree analogies. You know, do you put the Christmas tree on 24th of December and you get to only enjoy one day where you put a lot of effort into putting those ornaments and stuff like that? Or you started putting those things up after Thanksgiving time because, you know, you get to enjoy that Christmas tree for 1 month. So does your, you know, the different Charcot patients have different underlying medical conditions. Some people have a lot of space between BK and the Charcot, but some people are much closer to the BK or even death in this Christmas tree analogies. So is your patient 24th of December or November 23rd? So you really have to see, look at the background comorbidities in order to decide if you should do the reconstruction on those patients. So amputation does shorten someone's life. That statement is really false. It's a really associated factor for sickness and older age. What about function? Do amputees function worse than reconstructive surgeries? I don't know how many of the reconstructive cases the patients can. Let's see. Is it working? Actually, this is the biggest point of my lecture, but is the movie working on this one or no? Let's see if I can click on this. Well, this is the biggest part of the lecture, but you could see, well, you can see, but it was supposed to show that those people who had the Symes amputation and below the knee amputations, they actually walk almost normally, you know, compared to the prior to surgery. So, and how many of your Charcot reconstruct patients, you know, walk this fast? I wish I could show the videos. Some of the people were actually jogging with the Symes amputation or below the knee amputation with the hydraulic prosthesis on. So they actually function much better than those reconstructed patients with no motion in the foot. And again, if you go through that reconstruction, I talked about the deconditioning, how many of those patients can get back into walking right away? Well, almost none, at least 20 weeks of non-weight-bearing status, and most of the time it's actually much longer than 20 weeks. So all those times the patients are deconditioning every day. And we talk about all the risk factors that are associated with the deconditioning. So we have to really look at those factors before you decide to do any of the reconstructive surgery. So function declines more with the amputation than reconstruction. Actually, most of the times people actually function as long as they're able to, you know, rehab. You know, some of the very sick patients, they're not able to rehab. So obviously those are not the good indication for the amputation. But as long as patients are young and able to rehab, then they actually function much better than those reconstructed patients. What about cardiopulmonary reserve? To talk about this in the previous discussion, and this is a Pinter's article I was talking about, that their conclusion was that the amputees function at the cardiopulmonary capacity approaching their maximum. The capacity to walk long or short distances decreased with proximal amputation. Therefore, functional walking capacity in the amputee is directly related to the level of amputation. That's their conclusion, but that's if you look at their data and put it, you know, they don't have this diagram. I actually use their number in the literature, in the article to come up with this bar graph. And if you put their data on the bar graph, the conclusion is not really supported. I showed you that already, but the energy consumption and the velocity on walking is not really different from the mid-foot amputation versus Symes versus BK. So more proximal doesn't mean that you'll lose cardiopulmonary reserve unless you have an above-the-knee amputation. And I showed you different studies, similar design studies, a bit better design, more population, and again, the same thing that proximal amputation doesn't necessarily slow down the patients or increase the oxygen consumption. Same thing, other studies shows the same thing. So cardiopulmonary reserve decreases with the proximal amputation. Again, that statement is false. Actually, there are more data that doesn't show any difference between the distal versus proximal amputation. What about the quality of life? Charcot people have obviously decreased functional quality of life, but if you look at the mental status, mental quality of life component on SF-36, there's no significant difference. But we talked about it. A lot of those Charcot patients have a mental illness, underlying mental disease that SF-36 is not sensitive enough to detect the difference between those the diabetic population versus general population, but they're certainly lower in the functional status. But if you look at this study, that is one of the Swedish study that compared those people who had a current ulceration versus those who had a healed ulceration versus people actually had a minor amputation. The quality of life measure is not really different from those people who had a healed ulcer versus who had a minor amputation. People who has a current ulcer is much worse than the people who had a minor amputation, and this is not a really small study. What about the more major amputation? So this is a Wookage study. I'm not talking about those people had a Charcot and has an ulcer that could be treated with a wound care and the patient will be okay. I'm talking about those very difficult to reconstruct type of cases that the Wookage group did the amputation on. So they did a major amputation on those 13 non-reconstructible Charcot patients, and if you look at the pre-op versus post-op, both mental score and the physical score significantly, almost a 50% increase in the quality of life in both measures. Activity of daily living in a foot and ankle, specific measures, again, that almost a twofold increase in the quality of life with the major amputations. So quality of life suffers with the amputation. Again, that statement is false. What about cost effectiveness? So there's not significant studies out there. We kind of talked about external fixation and all that gadgets we have nowadays, being the surgical society on treating the Charcot problem in this country. There's one study actually looking at the cost of amputation versus salvage, not the effectiveness. The cost in this group is 93 patients. Salvage cases was $56,000 versus those who had a major amputation was $49,000. So amputation is still cheaper, just according to this study, but the difference is less than $10,000. So, what's the $10,000 if you get to salvage the leg? But the caveat with this is that what's the cost if you don't talk about effectiveness? And obviously the cost effectiveness ratio is cost divided by effectiveness. And what's effectiveness in Charcot patients? Well, is that the function, or is that quality of life, or is it 5-year survival? And we we discuss about all those three things. And they actually in the amputation patients, most of the time they have a better function and better quality of life, and 5-year survival was not really affected by the amputation. So if the denominator is the same and effectiveness is better with the amputation, then obviously the cost effectiveness is going to be much better with the amputation. So limb salvage is more cost effective. Again, the statement is false. So when we're looking at the major reconstructive surgeries, again, it's not the minor something that we could treat it with the local wound care and the minor amputation. I'm talking about the major reconstructive cases. There are a couple possible outcomes. And one is failed reconstruction, which is obviously not good. Limb salvage, but without function, which is not good either. If you salvage the limb with function, but it's not as good as prosthesis, is it considered success? Well, limb with function better than prosthesis, but patient significantly deconditioned and lost the independence. Is that a successful reconstruction? limb with function better than prosthesis without deconditioning. That's what we're aiming for. But a lot of times when we go to a lot of the conferences, limb salvage conferences, we kind of collectively call these limb salvage. And is that successful for the patient? Really have to have a couple of visits with the patient and try to find out what the patient want. Obviously, you can't really always go with what the patient want, otherwise you're treating everyone with the Vicodin. But so what you consider successful limb salvage, usually I draw the line where, you can see the black line there, the limb salvage better than function, prosthesis, but patient decondition, and the rest of anything above that, I usually advocate for the amputation. Not in the first visit, of course. The number one fear for those patients is amputation more than death. So you really have to have multiple visits to get to know the patient and his or her family before you introduce the idea of amputation. Caveats to this is when you're looking at the super sick patients, you have to really look at the 30-day mortality. And obviously, that below-the-knee amputation is not a benign procedure either. So a lot of times that the patient lose a lot of blood and require transfusion, and the 30-day mortality is one of the highest in the below-the-knee amputation. So make sure that you're not dealing with the super sick patients. And those patients, a lot of times, what I do is minimally invasive arthroscopic arthrodesis with the intramedullary nail type of procedure where I don't have to make any incision, just to try to salvage without going through the amputation. When you're talking about a lot of the bone healing in the normal patient populations, we are talking about fixation failure versus bone healing. Which one is faster, fixation failure or the bone healing? Because you want a bone to heal before the fixation fail. But when you're talking about these super sick patients, we're really talking about fixation failure versus death. So you want to have a fixation good enough to last long enough so that the patient can have rest of the 1 or 2 years of life in those super sick patients. So a lot of times when you have a severe Charcot arthropathy, a lot of times I just throw the IM nail without prepping the joint. And that's certainly give the patient last 1 or 2 years of life with the weight-bearing status. A lot of times they like to just play with the kids or play with the grandkids for the rest of the couple of years instead of going through the major reconstruction, being in a wheelchair, not able to do anything. You have to go to the wound care doctor every week. That's not a good way to spend last 2 years. So a lot of those super sick patients, I will do it that way. And of course, results in the patient-centered treatment. Again, you can't really go with that 100%, obviously, but you really have to listen to the patient. A lot of it is the religious reasons that you can really amputate, or a lot of the tribal reasons in Native Indians. A lot of times you can't just accept the amputation. So you really have to have multiple office visits before you can even introduce the idea. Here you go. Here's videos. So how many of your reconstructed patients can have this kind of gait after reconstruction? And these patients had an amputation, and they get to the level much, much quicker, sometimes as quickly as 3 months before they can even start jogging with the prosthesis. So what I do for those people who is not acceptable for amputation, this is what I exactly do, what I'm doing right now, show these videos. And a lot of those patients haven't been walking like this for years, and all of a sudden they see these videos with the patients running around with prosthesis, and they start accepting their idea of major amputations. And if they can really overcome the fear of amputation, that a lot of those patients are happy after amputation, and that statement is very true. Thank you.
All right, I'm going to finish up with our morbidity and mortality rounds here. For the record, I'm making notes based on his presentations because I think this is actually a lot of fun, because I think our talks are sort of opposite of one another to some extent. For the record, first of all, when I develop Charcot, you can all have my leg. I don't want it. I agree 100% that the road to salvage is often a lot longer than the road to BKA. And my personal experience is that most people who ultimately end up with an amputation regret that they didn't do it sooner, and that they're very actually happy with their amputations. But I think, you know, in essence, what we're talking about is a malignant disorder that is diabetes. These people, and we're talking about mortality a lot, it's not that you know, their foot is killing them. It's that their neglect in their disease process is killing them, and their foot is a marker for that. I think we all know it. I don't go to sleep at night thinking that I'm a murderer, at least not for that reason. And and so, you know, I think it's something to keep in mind. I generally tell people that if I'm going to salvage their leg, it's going to take 3 to 4 operations. It's going to take 6 to 12 months minimum, and that if they want to have a below-the-knee amputation, they're going to be up on a temporary prosthetic in about 8 weeks. And oftentimes that's better for them. And I actually push hard for amputation in a lot of cases. And the other thing that I do fairly routinely is I get my palliative care team involved. Because as we've spoken to for the last 2 talks here, I mean, death is inevitable for all of us, but it certainly seems like it's coming quicker for these patients. And sometimes doing nothing is the best option, not just BKA, but to say, you know, look at your global health and sit down with someone and have a sort of end-of-life care counseling session and say, let's establish some guidelines about what we really want to do here and what that patient's personal definition of quality of life really is. But so the final part of our talk here is I'm going to talk about IM rods and how to put them in. You know, basically the pitfalls of this and what I've encountered. You know, these are originally discussed by Gerhard Künchner, you know, surrounding World War II, trying to invent more inventive ways to stabilize extremities, get people up moving quicker, limit soft tissue damage, and an earlier return for certain function. And so what are the applications or indications for using an IM nail? Certainly sick host, as Dr. Shabiri was just saying. Sometimes, if nothing more, we're looking for stability in a sick host. This is actually a fairly quick way, if you can become proficient at this, at getting someone stability, particularly elderly patients. And then obviously we have our reconstructive side, arthritis, deformity correction with Charcot, which is really what we've been talking about. And then infection control, which I'll use either an intramedullary antibiotic spacer or even coat an IM nail with an antibiotic impregnated material when I'm putting it in there to act as sort of a permanent antibiotic spacer. Contraindications are many and I think mostly obvious. You know, active osteomyelitis in an area where you're inserting this thing, are you going to seed things, are you going to make things worse? You know, and proximal hardware, other things that may preclude you from simply getting this thing in here, but otherwise, I can get an IM nail on just about anything. But this is a perfect example, and like I said, I love showing my failures. This is a gentleman very interesting, to, you know, similar to Dr. Shook's case, who came in to me with neuropathic fibula fracture. We say, well, you're a terribly sick guy, your EF is like 5%, nobody's willing to put you to sleep. And so we'll sort of monitor this Weber B distal fibula fracture weekly with serial x-rays. But unfortunately, he comes back in, he's in a power chair, and he comes back in 2 weeks later, and he gets an x-ray, and his tibia is broken, and he's starting to drift into valgus and ulcerated his medial mal. So now what do? We do a regional block for him. So I think, you know, our anesthesia team did a sciatic block on him. And in about 37 minutes, we slip a closed nail in here. And as he said, it's this risk of hardware failure to fracture healing. And this is an interesting scenario where we had both. Because his tibia fracture here obviously looks healed, and his fibula fracture looks like it has decent healing. But as I would point out to all of my residents, the calcaneus probably shouldn't be underneath the fibula. And so what we've had here is actually that the calcaneus has failed and slipped out from underneath the talus. And so we have ankle healing and we have limb salvage, but we definitely have some degree of failure here. Again, this concept of super construct, so I'll move forward with it, but we talk about the advantages or disadvantages of this. Advantages, certainly speed of application, you know, relatively cost efficient compared to big limb salvage, so we're saving some money. Large surface area for stability. And this is a load sharing device that may decrease stress shielding and may limit non-union if you think that that's the way that things are working, which is still up for debate. So The whole goal of this is application and patient positioning. You can do this in any position, but I would tell you to do it in the position that you're most comfortable with. I've done things every which way, but I do a lot of this stuff, and so I tell you my preference is to do supine. I'm comfortable doing prone. I don't prefer to do this in a lateral, but the fewer amount of times that I have to flip a patient and move a patient depending on what hardware is previously in them, where they've had previous incisions and infections, it all plays a role. And positioning is not benign either. You put somebody prone for 3 hours and their risk of stroke, blindness, hypotension are all significant risks. And so even the way that you put a patient on the table plays a role in their outcome. But so make things easy on yourself, plan ahead. Don't find yourself halfway through a surgery going, son of a gun, I should have put a bump underneath this person. They're not far enough on the table. I'm too close to the wall because I have to pull my arm back like this when I'm reaming. Then I have to change my gloves every time I contaminate myself. Talk with your techs. Know that they're comfortable with where they're positioned in the room. You have to have a C-arm in here. There's a Neptune in there. There's a Bovie in there. There's lights. There's like 3 OR tables filled with equipment. And all of a sudden, everybody's moving. It takes 7 minutes to come in and do any one thing, and you're extending the time of your surgery. And then positioning your fusion, making sure to medialize things enough, particularly if you're using a straight nail, positioning things, making sure you prep high enough. We only do foot and ankle surgery, but prep above the knee. Make sure you can see the tibial tuberosity. Make sure you don't forget that there's a foot attached to this thing. You want the second ray aligned with the tibial tuberosity as best you can. Obviously, we have this rule, thou shalt not varus, err on the side of neutral or valgus, and try and keep from having any sort of translational component. Positioning your incision, one thing that you'll hose yourself in doing a central incision, you may hit neurovascular structures that are crossing under the medial aspect of the calcaneus, and you've done yourself this fantastic surgery and you're high-fiving, but you blew straight through their sort of lateral plantar artery or their medial plantar artery, and their foot's dead, but your nail looks phenomenal. And so incision is generally in the lateral 1/3 of the heel, sort of targeted out here. Be the x-ray tech. You have to be sort of the jack of all trades in this sort of thing. You have to be able to get perfect circles, and so having your leg elevated on some sort of bone foam or some sort of support so that it can be in a position where your x-ray tech can get perfect circles, and them knowing what this is, whether it's under image magnification, and knowing what you're doing. Because as we'll see in one of these cases, you can create a problem with a simple thing like putting in a percutaneous interlock screw that can be devastating for people. So know how to get the images that you need. Know how to get an axial that shows you where you truly are in the heel. Know how to get a true lateral that shows you where your nail is actually going. Because if you can't do this, you're setting yourself up for disaster. And then know your patient. This was a great one here. The image on the far right was someone who came to me obviously with a plantar flexed ankle fusion. She's got a tremendous amount of forefoot pain. She's getting stress fractures of her forefoot. And someone did me this politeness of burying this sort of home run screw 2 centimeters deep in the tibia from posterior to anterior, leaving some nice broken wires. And then we have leftover hardware from the initial surgery where she's got this cortical screw that has the head snapped off in the medial malleolus. So is this something that's even retrievable? Is this something that I can do a nail on? As you can see here, we managed to just squeak by our screw right there. It bent a little bit when we went through, but that's okay. And we get the rest of it out. But know what's above you. Does somebody have a rod above them? Does somebody have a knee replacement above them? Is it a constrained knee replacement that has a stem that's going down into the tibia? Have they had a previous X-fix that they have big holes in their tibia at some level that you should jump over rather than stopping directly at? Should always be spanning at least two diameters of the bone above an area where we've got a stress riser. So these are important things that you have to keep track of if you're going to do this. And then know your hardware. Is this something that offers internal compression? Is it straight? Is it bent? How bent is it? When you talk about things, they may range from 12.5 degree bend and valgus bend all the way up to 0. Are you going to get somebody who's like this in 20 degrees of hindfoot varus, and are you going to put a 5 degree valgus nail in them? Or if you're using the nail from the one brand that exists here, I won't name it, that has a 12.5 degree bend, are you going to correct 32 degrees of deformity for them and get a nail in there that's actually going to fit? No, you're probably going to be cutting out of some bone, some way, shape, or form. And so you really have to know what you're getting into and what your fixation options are. This is a guy who had a compartment syndrome about 10 years before he met me. They told him that you've got severe arterial damage, that you try and do anything to get your leg stabilized, you're going to lose your leg. And so he sort of went until he was non-braceable. He's got this equinovarus contracture, at which point, as he was saying, what's better here, no leg, a leg, or the leg that you have? And if anything, if either option is better than the leg that you have, whether BKA or limb salvage, then I'm at least willing to try limb salvage for you if you want to go through. I say, listen, this may fail, but if you'd rather have no leg than what you have now, then this is perfectly reasonable in the right host. So we do a tibio-talocalcaneal arthrodesis. We sort of truncate him a little bit. We certainly get him back into a more plantigrade position. We release his plantar fascia. We release his PT tendon. We fuse his talonnavicular joint. We do a dorsiflex first metatarsal osteotomy, and after about 4 hours of work, he's pretty plantigrade and pretty happy and walking better and actually brace-free in this scenario. So that's definitely a consideration, but he's definitely not our normal patient. And then knowing your bailout, know when the hardware that you have that may be made for foot and ankle is not going to be enough. As most of you know, if you've done an intramedullary nail, that they come in typical lengths, 150, 200, 250, and 300. And if 300 is not long enough, you have to figure out a way to accomplish this by some other means, whether it's an external fixator or what I would generally do, and I can't advise you to do it because it's off-label, is we routinely use a femoral nail, which generally has about a 4-degree bend on it. The femur has a 4-degree AP bend, but we flip it the other way, and we send it up the leg. And then you can get a femoral nail as long as you want, 320, 340, 360, 380. And so this is a femoral nail that we've used here to span over the midshaft tibia. And my other advice is always going long. But doing this with a partner, doing this by yourself, it's very difficult to do by yourself. If you're going to do it, you need provisional fixation. So I usually use pins oriented like this, anterior to my to where I'm going to be reaming and drilling. It takes some getting used to, but it can be something that you can learn to do pretty quickly. And every once in a while, you like the wire so much that you can actually use it for a percutaneous screw to sort of augment your fixation. Making sure that you're getting good imaging, getting a good axial, that you're central in the calcaneus or lateral so you're not cutting out. Making sure that the fibula is lining up with the lateral process of the talus for your guide wire. Then putting your guide wire in. And this is sort of an example of how doing something with a bent nail or a straight nail will change your entry orientation. The straight nail, we obviously have to be a little bit more medial, or you can cheat lateral, but you take some risk in that you're going to preserve some of your malalignment there. And we drill and open with our reamer, getting past the physeal scar. Again, knowing your host, if they've lost their talus, you may have to get a little bit bigger because generally the distal end of a nail is about 13 millimeters and the reamer is about 13 millimeters or 14 millimeters. So if they don't have a talus, you may have to go further than the physeal scar or else you risk sort of breaking their tibia. Ball tip is pretty self-explanatory. This is your guide. And then reaming. Reaming always on forward, ream higher than you think that you need to ream 1 to 1.5 millimeters bigger than your device, and know what you're putting in there. This is a case of somebody who had had a previous infection. We think we're going to be inventive, and we're going to coat our nail, so I use a femoral nail here because I can get a 9 millimeter diameter rather than our standard 10 millimeter diameter. So I ream to 12, I coat the nail with what I think is less than 2 millimeters of antibiotic cement, and then I smack it up there and shatter the person's tibia. So luckily for me, I'm using something that I can use a longer device. So I take it out, I leave my guide wire in there, I re-ream higher, I re-ream larger, and I put a 360 millimeter nail in here that's coated with antibiotic cement, and their tibia looks like it exploded, but they heal uneventfully and move on with limb salvage. This is one I did when I was a resident. It's great to learn when you're a resident and do things. You don't ream high enough and you try and smack a nail past something. If it's not going through, it's probably a reason. We didn't ream high enough and we break the anterior cortex of the tibia all the way down. Again, we pull out our shorter nail, we ream higher again, we put in a longer nail. So again, this is a prime example, and one of my residents just presented this case the other day because one of my partners did this, and this is when bad decisions go badly. And you say to yourself, I want to get out of the operating room and I've done something bad and this will probably be okay. Bad technique plus bad decision equals bad problem equals probably bad outcome. So as you can see here, there are two interlocks side by side up at the top of this nail, which means something bad happened because there's only supposed to be one in that position. And so what happened was somebody was not getting a great perfect circle. They drilled out the anterior cortex of the tibia. Then they realized it. Then they drilled another 5 millimeter hole directly behind it actually catching the nail. So now we have a 5 millimeter hole in the anterior cortex, a 5 millimeter hole in the middle of the tibia, and then this person obviously had an external fixator on at some point with an external fixator pin site within a centimeter of the tip of the nail. So we're missing a lot of bone here around this area, and we're right at the isthmus, which is a bending point anyways. So what happens? We have now a crooked leg. And so now you do what you probably should have done when you realize that you drilled out the anterior cortex. You take everything out, you put in a ball tip wire, you get yourself reduced, you ream higher, and you put in a longer nail so that this person can have a functional leg again. Again, just sort of knowing things about your nail, knowing if it's a compression nail. There's different things on the market where it's compressing. Is it only at the ankle or is it at the subtalar joint as well? This is a prime example. This nail compresses at the ankle and the subtalar joint, so when you put it in, you think you're in a perfect position, and then you get your 7 millimeters of compression with this nail, and all of a sudden you say, holy cow, I compressed the nail straight out of the bottom of the foot and I lost my axial screw position, basically. It's getting pretty proud here. And so you have to know your hardware, your host, and how they're going to go together. Using an end cap, this is not just to prevent bony ingrowth and ease of explant. This is also to create a fixed angle construct. So again, knowing your hardware, knowing biomechanically what you're doing, the end cap is creating a fixed angle construct between your axial screw and the calcaneus, or in this case, the blade screw. And then doing something to augment. A nail is fun and sexy and huge, and it's the biggest thing that we can put in there, but is it enough? And there's definitely literature to support that this augmentation screw, whether coming from proximally or coming from distally, is an important part in increasing stiffness of your construct. And then finally, knowing your specialist, because ultimately, some of these are not going to work out so well. This is a gentleman who had an ankle Charcot, a large amount of bone loss. We treated with femoral head allograft that we buttressed with this large lateral plate and snuck a nail through it and sort of interdigitating around it. And as you can see, obviously here distally, that plate's not hugging the calcaneus very tightly anymore. Some things are starting to back out. And he has infected hardware here. So now it's time to switch to a BKA. So knowing what your other specialist needs. You want to preserve the posterior flap of the leg. You try not to violate that. And if possible, you try and stay away from 10 centimeters from the tibial tuberosity, because that seems to give people a good functional working length for a below-the-knee amputation. You start going right up in their tibial tuberosity and you worry about infected bone up there, they might not really have a good outcome. And nobody who's coming in after you is going to be very happy if they say that they have to remove an intramedullary nail or call you in there to remove an intramedullary nail just so that they can do a BKA on top of you. So like sort of special circumstances, I'll finish up here. Nailing after a talectomy can be somewhat challenging because one of your malleoli is probably still going to be there and kind of get in the way of you docking. This was a gentleman who had a talar neck fracture and then had avascular necrosis, had open wound. We excised his talus. We put in this antibiotic spacer donut. We treat him with a spanning external fixator until his tissue calms down and his wound's healed. And then we osteotomize his medial malleolus and we bring him down and we dock his tibia to his calcaneus because he already had dead bone in there. So my philosophy is if you just had a big piece of dead bone and you're a neuropathic patient and you're a compromised host, probably putting another huge piece of dead bone in there is fairly risky. There's literature to support that it's fairly risky at this point with a high degree of complication with femoral head allograft. So having a shoe buildup is not such a bad thing for a limb length discrepancy. So sort of similar patient I was talking with you before, sort of closed nailing. I think as Dr. Shabiri was saying, closed nailing is a great option for you if in a sick host with an unstable extremity. It's something where you can say, listen, I'm basically doing a percutaneous pinning here, but not leaving external pins that are going to be a source of infection. And you can get this accomplished in 30 to 45 minutes and get yourself out of there. And then finally, what happens when things start to fail? Don't bury your head in the sand. You see something that's going to be an extruding nail coming out of the bottom of the foot. Don't hope that it just stops. Do something. Either dynamize the nail so it starts to rise or stays flush, or remove it preemptively before you're staring at a wound with exposed hardware and an possible infection rather than just a prominent nail on the bottom of the foot. So I think probably the most important thing I can tell you with all these patients is that you have to have an open line of communication with them. They need to know what they're getting into. This is a big deal. It's a big procedure. It's something that is oftentimes happening in compromised hosts, and you have to educate them that it may not be one surgery. It may be multiple things that are happening, And if that paints their decision and they choose to do a below-the-knee amputation, then that's better for you and it's better for everyone, because it means their eyes are open to what's going on and they're truly choosing the thing that's best for them. So, my final thoughts: if you can dream it, you can nail it. I've nailed everything. Know your hardware, know your device. Go long, always with the nail. I have not put in a 150 millimeter nail in the last 6 years. Longer is better. It just seems to be fraught with complications to do shorter nails. And know your bailout options and know your limitations.